It's just take up and we do things that are unnecessary to be done. But when you look beyond the things and look to say, but why Sibongile is doing this? And when you try to follow up, you'll find that actually this person is not normal. This person is depressed and this person is dealing with a lot of issues. But our healthcare system, unfortunately, it's in a center of all those things. And I know where I'm sitting that our healthcare system carries a lot of burden in our country to fix almost everything that is happening in our country. So we would like to apologize in front if we are going to be a bit harsh to other responses, because we are also human. Some of the things we've gone through them, and they will touch those, unhealed wounds. Sometimes they will open those old wounds. Sometimes they will do all those things. But I hope that everything will go well. So without wasting any time, colleagues, we have a program in front of us, and I'll just outline the program, which is a welcoming, which I already did, and then it will be overview of report and data, and then we'll have community priorities and testimonies. Under that, we have subtitles of stockouts and shortages of medicines, staffing and waiting times, art collections, art continuity, key populations, index texting, infrastructure, plus clinical conditions, TB infection control, and then we'll have partner organization inputs. And then after that, we'll have reflections from our partners, PEPFAR, district support partners, District Department of Health, Provincial Department of Health, and I think also we'll have Office of the Health Compliance Standards, and we'll have the chairperson of civil society in the Northwest also be part of us. And as I've indicated earlier, and acknowledge our partners in Ritshidze. Ritshidze is formed of 5 organizations of people living with HIV nationally. So we'll have maybe 2-3 minutes of the reflections from each of those organizations that are part of Ritshidze. So in that note, and without wasting any time, I will hand over to my colleague Mary Nyati to give us the developing the report and the data.
Ngiyabonga, Chairperson. Thank you also again for the opportunity. Today, we have launched the 3rd edition of the Northwest State of Health Report, developed using data from the Ritshidze community-led monitoring. Ritshidze monitoring takes place on a quarterly basis in 28 facilities across the province, including 10 facilities in Bujanala Platinum, 8 in Dr. Kenneth Kaunda, and 10 in Ngakamudere Mulema. In today's meeting, we are deep diving into both the progress and challenges across the province. We will hear directly from people living with HIV, people who use drugs, sex workers, the LGBTQIA+ community members, and other public healthcare users as to real experiences of using the clinics in the province. Data is collected through observations as well as interviews with healthcare users, people living with HIV, key populations, and healthcare service providers. The data in this report was collected between April and May 2023. Interviews took place in with 18 facility managers. Observations took place at 18 facilities. Interviews took place with 1,072 public healthcare users. 49% of the 1,072 public healthcare users was identified as people living with HIV, and 14% was identified as young people under the age of 25. Additional data was collected between July and September 2022 amongst communities of key populations. Interviews took place with 558 gay, bisexual, and other men who have sex with men. 537 interviews across people who use drugs, 488 sex workers, and 243 trans people. Quantitative data related to stockouts and shortages of medicines and other health products was collected between May and June 2023. Data collected took place at 72 sites across 4 districts, 17 sites in Bujanala, 18 sites in Dr. KK, 16 sites in Dr. Ruth, and 21 sites in Ngaka. The first group of issues that we are going to talk about or report back about is stockouts and shortages of medicines. Stockouts and shortages of medicines and medical tools cause disruption, confusion, cost, and can detrimentally affect treatment adherence. This year, there was 404 reports of different medicines, contraceptives, and vaccines being out of stock in total across 72 facilities, compared to 398 reports across 57 facilities in 2022 and 895 reports across 56 facilities in 2021. The worst hit district this year was again Ngaka, followed by Dr. Ruth Simukhomote Mompani, Bujanala Platinum, and Dr. KK. Similarly, last year, while protocol dictates that either pharmacists or professional nurses should be responsible for stock, receiving orders, updating stock availability on the system, enrolled nurses and enrolled nurse assistants, some facility managers, and sometimes cleaners are also in that capacity at some sites. This year, only 17% had a pharmacist and only 28% had a pharmacist assistant, adding to the workload of already overburdened nurses in the sites without pharmacists or pharmacist assistants. 42 HIV medicines were reported as out of stock, including 22 reports of the first-line TLD being out of stock and 12 reports of Abacave being out of stock. 46 TB medicines were reported as out of stock, including 24 reports of Rifafor in particular being out of stock. 24 analgesic medicines were reported as out of stock, including 17 reports of paracetamol being out of stock. We have recorded 33 contraceptives that were out of stock, including 28 of implants being out of stock in particular. A number of challenges were revealed during the data collection, which include the facilities at times receive stock that is close to expiration dates. The facilities receive less stock than what they've ordered. Facilities borrow from each other during shortages and return when they get their stock, creating a cycle of shortages. The facilities often don't get their stock on time due to unreliable transportation. Facilities also don't have enough space to store the medicines. And that during load shedding, vaccines at facilities without functional generators are spoiled. We are going to have some recorded stories that speak about the issues that we just highlighted.
And o tla bo ile mono clinic o lo collecta dipidisi tsa hao tsa high blood. Ha ke fitla tabe ke fotse line eo e telele jwalo, ha ke tshwanetse hore ke tlo fumana dipidisi tsa ka tsa high blood, ho tabe ho thi dipidisi ha diyo. Kana ho hloka dipidisi tsa ka tsa high blood ko be ya bophelo ba ka kotsing. Ke tlabe ke na le sedidi taba ya pele, ke tlabe ke sa kgone ho ka sebetsa hantle hobane ha ke na dipidisi tsa ka, le hore ke nka letsatsi la ka la mosebetsi wa ka ko ke sebetsang teng ke ikopa letsatsi ke tla mona ho bo tshwanela hape ke tlo kopa hape letsatsi ke boela tleliniking ke tshenyo hape ya mosebetsi wa ka. Ke ne ke ka thabela hore immediately hela ha re kena maybe ba ka etsa nakonyana eo ya hore ba re bolelele hore batswadi ba ka kana ha rena ba tlo nkang treatment ya high blood ha rena dipidisi for ndaga tsa high blood le tle le neng hore re se ke ra le senyetsa nako ya lona le mosebetsi wa lona ho ikopa fela for mahala.
Ko Tshedifelo clinic ke khona ho ya go seng ke lo tlhola fao ntshegare otlhe ka tla so ha ke tshwere ke kalalo ke tlo tswa ka 4 ha ba chaisa bo myself after all ha ke etsa go tsena ba etsa go nthusa treatment ya bone ya short ene ke ya ka gona ya no ke tlhotse teng la bone ka di 4 gape ke ya ka di 4 ya no mo gare ga beke mo gape ga ntshwantse ke nne ke go tlhoko ke go sheba gore a treatment eo e tlile or ya nna ka e fumana e feletse so ke ka tlhakatlhakana nako nngwe ke a peinelwa bosigo le kgwao pilisi di fedile ka mo ke boleletse gore ne ke kgona go reka nako nngwe a tšheletenyana le teng ke ya chemist ke go reka gore net go kokobele la ka me ha dio mosasi di ke high blood ke damage of lungs ebenaselo epilepsy le go ruruga ga maoto go a diragala nako nngwe and then nako nngwe ba sakra treatment e feletseng ke lala ke fupelwa bosigo ke fofulela ke sa robale ke phethoga yana dilo tse di tshwanang le tseo ntho nngwe ne ke shebile ya dilase yanong ha re kena mo ha re kene mo jareteng so ha pula ena ha re itse gore re ye kae mme mongwe a ba salentse a botsa gore kante a re tlile mo strateng or re tlile mo tleliniking na a ba re arabe ba shutha ba tswa mo go rona ba re bitsa di 55 mole mare ba stara ba nraela ba re treatment ya shorta engwe a e setle ke sa itse yanyana.
We are going to have recommendations from the chairperson.
The recommendations are the Northwest Department of Health should ensure that pharmacist assistants who had their contracts discontinued in March 2021 are reinstated by September 2023, fully recognizing that they are the first to notice when there is stock running out. This should also relieve pressure on professional nurses and other cadres to focus on their core mandates. The second one is to complete the decentralization of the provincial medicines depot through the establishment of the Rustenburg and Potchefstroom depot to ease burden on the Mafikeng depot by June 2023. Thirdly, address the disparities in transportation of medicines to facilities level that negatively affects some sub-districts through a review of its SMMEs partnership by October 23. So now we'll go for staff and waiting times, which will be led by Ludik.
Okay. From out of 1,072 patients, public healthcare users, only 15% thought that there were always enough staff to meet the needs of public healthcare users. Improving the state of healthcare services provided in our clinics so that all people living with HIV and key populations can access friendly, welcoming, and quality services depends mainly on having enough qualified and committed staff in place. Yet, while up from 11% last year, this year still only 15% said there was always enough staff at the facility. From 18 facilities surveyed, only one facility reported that there were enough clinical and non-clinical staff to meet demands. There is still a long way to go to fill the human resource gap, as 83% of facilities monitored remain with too few staff to meet demands. Of facilities reporting shortages, 43% facility managers attributed shortages there not being enough position in the organogram to do all the work. 42% highlighted one or more unfilled vacancies, according to the facility managers. The most commonly understaffed cadres were professional nurse, enrolled nurses, enrolled nurse assistants, pharmacists, and pharmacist assistants. The most common vacancies were among data capturers, enrolled nurses, and pharmacist assistants. 56 of facilities specifically wanted additional clinical staff from PEPFAR district support partners in the province, the ORAM Institute. Further, 17% wanted ORAM to provide more linkage officers, 11% wanted more community healthcare workers, 11% wanted peer navigators, and 22% wanted social workers. However, PEPFAR funding for critical HR posts have only reduced in recent years. Average waiting times have reduced in the last year in facilities monitored in the Northwest, down to an average of 4 hours, 14 minutes waiting in the facility. This is including time before the facility opens, and 4 hours waiting after the facility opens. However, some public healthcare users still spend hours at each visit to the facility. The average waiting time was over 3 hours in 16 facilities monitored, over 4 hours at 8 of those, and over 5 hours at 4 of those. This is a very long time to spend at the facility, in which people are usually only seen for a very short consultation. And this is a major source of dissatisfaction for those who experience long waits. 92% of public healthcare users interviewed in the province still think the waiting times at the facility are long, with 71% blaming staff shortages, 41% blaming staff not working or working slowly, and 74% blaming disorganized filing system. In fact, filing systems were observed to be in good condition in only 33% of sites monitors, mostly due to filing rooms being too small to maintain. Messy and disorganized filing system increased delays and increased the burden on already overstretched health workers. The average earliest arrival time has improved from 5:54 a.m. last year to 5:26 a.m. this year. However, many people still begin queuing early in the morning in an attempt to get seen more quickly. 14 facilities still have an average arrival time of before 6 a.m. Of 517 people who arrived before the facility opened, 22% reported feeling unsafe or either very unsafe while waiting for the facility to open, worsening from 9% last year. While a circular was issued in May 2019 by the National Department of Health calling on facilities to open by 5 a.m. on weekdays, none of those monitored even opened before. Now we move to recording stories.
Nna ke tsamaya mo tsholofelo dijara tse dingata tse. Last month ke ne ke ile ko teng ha ba treat batho alright and di toilet tsone di fail and how kena ba bangata se gore staff sa shota mare service e tsa mastadaga and re dudiswa ko ntle ko strateng re fola line ko teng na go ngwa bata tshwantse le dule re bangata from there le tsena mo tere ke nne tere tla tsama ka line mare le ba isimbo sister body e ba dula go ba khondro wa le tlana ko e ba re bolela gore re tla lata last week ya ko ke sa batle go ya ko teng ke ikela ko mo go entšha e mo tleliniking mo ene ba re batho ba golo ba kene pele ba ya ka o ka di age tsa rona gore re batho ba kanang kang service se fiwa pele batho ba golo ba kile ka ya kwa ka ba mare ke tsamaile ka maoto still ka next na shilta go palama go tsamaile sebaka mare tsholofelo e gaufi too much a ke nke le 30 minutes mara ha ba se ba nthusitse le bone ka re ba ile ba mplela gore ke se ka tlhola ke tla mo ke tle mo tsholofelo mo ene plekele e siametse batho ba Alabama le batho ba mole ba ya gore dipilisi di so tleng then re ntse re emetse stock sa dipilisi o tla tlaneng or ba kwala ga nako mo fatshe gore o shotile ka dipilisi nteng o tla tlaneng mare le kgale o ne o dutse
ke re batho ha o ile sepetlele o tla bo o ile vroeg le batho ba theogelang mo o tla nne sa le o dutse batho ba batlang ba tla go kry-a o ntse o dutse mo bone ba tswa wena sa le o dutse ha o bitswe ha o itse batho ba dirile appointment le batho ha ba nagane le di-patient gore eng e ka re yaanong batho ba wa e sa le batlile a bana le discaptine ba bangwe a bana nex dijo ha o itse go diragala eng go wa batho ba tshwantse ba tshware batho ba bone ka tsela e yana ka go ko sepetlele go te batho pele a go thusiwe batho ha sena nex like mo thuse ka gore o thogetse ka lebakeng la patient a kege re setse re tshaba le go ya hospital gore ha o sena tšhelete o tlo go dula o dutse hela yana mo tshepone nako ngwe tla ba go romela nako ngwe kula ge o tshwanetse o kene ka casualty ba bona gore mo tsietsing ba tlo ba go ntsha ba re o ye ko tleliniking ko locationeng ka nako e o kana wa thusiwa after ha o etsa go thusiwa ba re ge o itse gore the following day o ya ko tleliniking mo locationeng
most of the time ko tleliniking mathata ke na le ngwana nna attitude ya di sister the way they behave towards patients a ba buile batho pila ba fella batho pelo ga ba explain le batho dilo most of the people ba tshwanang le rona ba lwalang o ka se be motho dipilisi felo sa motlhalosetso gore why go change ditse ka tsheko go fatse di so ko tleliniking ya letlhabile o ka se kry file ya all the time e ka nna motlholo di file di phila di tinitse ba sa tlhalose kana nke ba ruta next medically like a ba ruti batho ba ba nang treatment because of batho ba HIV positive you have to teach them so ko tleliniking ba leka communication ga ba tsele batho matsapa wa iwela taba gore once in a while batho ba positive a re tshwana re strong ka o tshwana ba bang ba need counseling once in a while or motho sa give up a default mo medication why immediately he o lena ka bolwetse bo every day o kono bona gore o kira education o kono dila ka bona better than o le clueless suggestion box ya bona ra kwala re tsentsa ka mole ke sure dilo tse di ka molange ba di bala angere ke nna mo bona ba di tsa ba di fotela go khole go bila ba sa ebia these days because of nestle re tsentsa selo because of a gona sepe se kile ra se go suggest ka sa change they are always late go tsena go mmereko they are quick to go to lunches they take long breaks baya breaking ba botle ge ka mo reception ba tswa baya lunching ba botle ga gona o sala ba luncha ba botle batho ba ntse ba lla ka clinical tlhabile to be honest we have complaints bokoko banna sebaka ko tleliniking filing system ya ko tleliniking e poor waiting period a se ba ikwalang gore re o khona ya tleliniking ka 4 o boe again later ka 4 le gona yang gae o tsogile ka matsa selo tsena ko tleliniking botso re tlo fetsa wa ntla go fitla go motho o dileng ka 9 o tlo go tsamaela pele because of file a go itimetse the better way they can do gore if ka tsheko ke di 1 ba ntse di file tsa ka o sanetsa di thuka tsheko batho ba di thuge batla ba kere di file di le mole system e ba lo ka ba better than gore every day ho tsena go tleliniking sentse no bo batla file go marene ba itse gore data go ka date ya no ke problem ya no te ba thoko tleliniking ya bana discipline gona motho ba discipline including lena mme o mogolo go tleliniking ga ke bone mmereko a game because of batho ba misbehave antsa le teng
selo sa mathomo clinic ya rena e na le disaster engwe e serious ho ya for medication ba botsa gore medication ha o teng and ho ba tlhalosetsa gore whatever se le mphang sona sa lwatsa ba botsa gore you had to drink it o tlatla re tlo check and ho tsena ba o check ba o diagnose ka matlo ke timeletse ke file tse 3 ko tleliniking he ke ba botsa ba re di file di teng no file to be found ke tsentse ke tsamaye ka buka every day ba ngwalle ke tsamaya ka yena ba re ke tsentse ke ishe ko tleliniking a ke nyake nka se ishe another thing happened the receptionist tsa ka mola le whatever se se leng ka mola he ba ya breaking ha ba botse batho re ya breaking ba tswa ba le 4 ba ya tea timing ba tlohela batho ho le fela so selo tsene ka 4 o'clock ko tleliniking o tswa ka 3 ya manjubana o emetse gore o tlo checkiwa. And then se seng hape di-toilet tsa ko tleliniking ke disaster e nngwe, like it's hell. Di-toilet tsa ko tleliniking a di na metsi, a di kolomakiwi, a ba beye di-tissue. Kore ho tla o kry-ile newspaper, you just help yourself ka newspaper. Ha ke nyaka medication ke ya ko Clicks ena wa reka a ke bereke. He ke kry-ile motho a ka nthusang ka 100 ranta ke ya ko reka dipilisi ko Clicks. Ho tsena ko tleliniking ha ona dipilisi tsa prevention, ha ona dinalata, a hona selo se se betere se se tsamayang a se teng. Hona bana ma security ba sota out di-file he ba le ka go di-consultation. Security mmere kwa sana go gata fela gore go se ka nna le tlhakatlhakano ka mo tleliniking, se sota out di-file. O kry-a ba bitsa file number mamang e ko doctor mang, he o le koko o shile file e se teng, tshwanetse koko a tsamaya a ye ka kwa a yo nyakana le file ka kwa ko file room. Ba ditleleke di le teng ga o tsena ba netse di-phone ke mogosi wa last week gore mang o bethile mang o irile. So this need to stop, it need to change, but say community serious. Le yone go ka tsena o kry-a go na le di-nurse tse pedinyana ba goga maoto ba lebeletse child, go lebelela mang sa le ile teng ka 11 o boa ka 2 a tsena kwala a nnile phone ba tla o tla dile tsa weekend.
Ke tsamaile thata mo tleliniking ya rona ya Lethabile ge ke ya file ya ka e ntsha malwetse a ka otlhelele e timetse. Ge ke tsena ko teng ba ntirela file, ge ke ya kgwedi e latela file e le e latlhegile ga ithe e le teng, e be ke change ke ya ko Brits, e be ke ya ko Krishna go na le tleliniki ko teng. Ke tsamaya ko Krishna tleliniki gona beano ke tshabile ene ke gaufi kana ke bua ka tleliniki e nna ke le mo gaufi le yone. Ka re ge ke theoga straight ka strata e se kgale ke a tsena.
I'm sorry, you're having a bit of technical challenges.
Mo tleliniki ya mo Lethabile e ke reng ke ya rona ke ipatella ngwanaka ga gona senka tsira le gore ko tlhola kwa motshegare o tlhelle ngwanaka bophelo ke bame ga intshware pila ke tlogela tleliniki mo thokwaka ga intshware pila mara go sena senka tsira go bolela le molwetsi bolela le ene sentle ene molwetse le ene re ithute re le balwetse ge re tsena ko tleliniki re boledisanye le bo sister Pila.
Nna ke tsena ko ke tsamaya ko Solofelo tleliniki, so my issues for now ke shapo nna by the service, the community o tle be re le bangata, so service is slow. So if government will provide more nurses gore the service will be on speed up, re ska dula sebaka se stelle, cause other people will be ba sa clinic ba tsaile bo di medication tlala lone ke bothata. So department ire maness not for temporary but for a permanent thing. Go clinic ya tsala ka mo past 7, so eventually ra ema ko until 8:30. After 8:30 is when then batla ba tsa di budi buka, then ke line tlebe e simolola go tsamaya e napa o tlile maybe ko clinic ka bo mathu if go speed up wa ka speed go bediwa ka speed o so gone ha ile taba ya gore ba bikinyana they will be working over ko ba bereka staraga manese a bikinyana a ba ska na more pressure te gore ba bereka mo tlase ga kgatello.
Firstly, go to fellow clinic. Ge o ya they judge you ba o sheba gore motho yang ha o kena ka moteng ba go consult ba gona ntsha information ya gago, maybe the person o leng wa assist o tsebana le the otherness ba gona go sipa ka wena o gona kena ka 9 for go etsa family planning, which is gonna tswa ka 1 or ka 2 impilisweni, because impilisweni it was fast, and when it's fast hona je e chinchile because nurse ona le teng ne le khalate ali very fast. Ke decidile go ya ko new clinic is very far
for nna. But anyway, ha ke sebetse, but because of if I can walk there because service thing it's very fast and they don't judge everyone. But to some more fast and ukhono kena ka 7 ka 80 watts. Yeah, Solofelo Clinic it's very near mo gonna. But new clinic is very far for nna. Ha ke sebetse, I can walk 45 minutes. Ke sebedise tambai, but ha ke na tšhelete tambai, but it's best for me hore ke walk so that ke kgone kry service ya teng. Most of the people ba ileng gore ba tsaya dipilisi tsa chronic, they decided gore ba dule because of ha ba treat gantle. And ba tshaba le gore ba tla ntsha di-status sa bone. As I'm a youth, I get to be anything about prep. I wish I could banjwetse ka prep or sebetsa yang or bang offer every time when I get good clinicing. Ke tseba fela batho ba itlhalosa ke le mo strateng ba tlhalosetsa gore prep e sebetsa yang and then we nwela eng.
Nna ke tsena ko se ke tsamaya ko Solofelo Clinic. So my issues for now ke sharp nna by the service. The community o tle re le bangata, so service is slow. So if government will provide more nurses gore the service will be on speed up, re ska dula sebaka se stelle because other people will be ba sa clinic ba tsaile bo di medication tlala lone ke bothata so department ire manes not for temporary but for a permanent thing. Go clinic go tsena ka mo past 7. So eventually ra go ema ko until 8:30. After 8:30 is when then batla ba tsa di budi buka, then ke line tlebe e simolola go tsamaya and napa o tsule maybe ko clinic ka bo mathu if go speed up wa ka speed go berekiwa ka speed. O isa gone ha ile taba ya gore ba bikinyana they will be working over ko ba bereka staraga ma nurse a bikinyana a ba ska na more pressure te gore ba bereka mo tlase ga kgatello.
Yeah, it's a mixed bag for the West. Because the waiting time there's a filing problem and there's I think a general management problem. Yeah, the filing system, the ladies that come in the morning, there's one lady, dedicated and committed lady that comes in the morning who takes the cards from us, the people who we queue. When we come in the morning, we queue. So there will be 40 plus people, 50 plus people queuing there in the morning, as early as 4 o'clock, then we queue. She comes around 6 o'clock, past 6, and then she begins to take the cards. And after which, then she records the cards as per sequence when we came, and then would record mo booking on the book. And then as she records, she dishes out the ticket numbers. So the first one will be the number 1 and all that. And then we go to queue for blood pressure and all that, and the weighing system, and if there is diabetic, if the machine is there, of which the machine, 3/4 of the time the diabetic machine, the small machine is not there. Yeah. So if it is there, then they'll also take the recordings for the diabetes. And so after we did the exchange of the cards and then you get the number, we queue at the for that blood pressure and all that. So there also we then from that time 6 o'clock, after we take the cards, then we will have to wait for others because it's not like they come 7:45 and all that. Some start drinking their tea. The main problem is not per se for the getting the tickets and then the numbering system. The main problem is waiting for the vitals because they'll come and pick the machines and all that. And sometimes it's one person and it's a group of people that come for assist. Check Letlhabile, the population of Letlhabile, I think it's about plus minus 250,000. The last time I checked, I think it's my 2017 when I did some research of some sort. So it will be more than 250,000 now, if you check everything. So, okay, that percentage that is coming, now it's increasing from that 50, it's now 100 and something. I remember the first batch, that lady who records the cards, she said she took the cards from 110 people the same day that there was a problem. So 110 people had to queue. to go and queue also for the vitals. And then, okay, the more you get your vitals recorded, how much weight and all that, and blood pressure, this and that, then you go to the third phase that I was talking about, to the consultation rooms, then a waiting area as well. The main problem is there that all the people who go there, they have to get their files first, because the nurses in those rooms, I think it's 3 or 4 rooms, the consultation room, they have to obviously get their vitals that were there and record them in their files. In each file, when they come, each individual comes into the room, and then in the absence of those files, there's nothing they can do. So the last time I was there in question, and then I was worked up, I'm sorry about that, is when, and it's, of which is happening every time I go there, is that we wait for, in the third phase that I'm talking about, the third phase in question, in the consultation room, the files are not coming. Okay, the problem that is, because while I was worked up, I must start there. I spoke to the people and they say the operations manager has been told this and that. But I thought maybe the presentation, let me hear from, like when you speak to somebody who's maybe more at a level, I'm not sure, medical, I don't know, a comparison. And then I spotted a guy who was also vocal and said, let's go and meet the operations manager. We went there, just to cut a long story short, we got the assistant director there, luckily being available. So the operations manager, we asked her, ma'am, are you sure of what the problems on the ground? And then, okay, obviously I don't know what you're talking about. Explain, please. Then we explained. People are queuing there, then files, they're not getting their files, or the people are getting files before others. People who are late are getting files first. Okay, and then we ended up, the assistant director, this matter caught his attention. And then he joined the discussion. And then he insisted that we go first, and then he listened to my problem first. But the operations manager said, no, let's capture what the 2 guys are saying, me and the other guy, the complainants, and then we'll go there, which was fine for me. Then we first went to the rooms instead of waiting for people, because they picked up that we know our story, that it's the filing system. All the people are waiting for it, it's a must be. Then we went to the filing room, and then they closed the door, they called they excused everybody, and they called all the staff. So it was a staff of 6 or 7 that in the filing room themselves, including the lady who takes a card. And then they ask them to listen to our complaints, and then they can revert to that later. And then, we raise our complaint, of which they knew. Surprisingly, they themselves, they supported us. They say, but management, we told you that we have this problem. The problem that, just to wrap up everything, there is the spaces in which 3 people have to get. They have their cards. They have each get a bundle of about 10 to 15 cards that they have to check, and then they classify them according to age. The way they told me, the 50s to 60s, 60s to 70s, and whatever. So, and then this one has these 2 have a 50 to 60, and it's only one thin row. So the one, because only one person can get in one, and then to draw the files, the other one has to wait with those 20 files, 20 cards. So they cannot work simultaneously and come back. And what is happening here is also happening in that other row and in that other row. So you'll find that if there are 6 or 7, only 3 people are working, the others are waiting. And obviously it will involve a lot of talking and all that in between, because the other ones are just idling.
We are going to have some community stories from the floor, speaking to the issue.
Dumelang.
Good morning, everybody.
Na a ise ke kopane le mathata go tshwana le ke bona nga tlhagella mo di TV nga.
I, for one, have not experienced what I've just seen on the monitor.
Okay, ke le ka ba le problem the other day.
I had a problem the other day.
Ne ke dutse ke dutse ke bona go na le some challenges mo go nna mo bonneng jwa me.
I have experienced some challenges, health-wise.
So ke a dula ka ipotsa gore go etsagalang, ke a bua le my other cousin a mpotsa gore okay tsamaya ye ko tleliniking.
And then my cousin told me to go to the clinic.
So ka se mo tsietsie ka tswa mo go ene ka ya ko pharmacy ka reka dipilisi ka di nwa di a fela.
Instead of going to the facility, I went to the pharmacy and bought the tablets.
So ka bona gore ga di a nthusa ka sepe, so ke a boela ko ene ka re ke rekile dipilisi a re tsamaya ko tleliniking go batlega lemaola ko tleliniking.
So I went back to my cousin, told him that the medication that I bought at the pharmacy did not help me. So he advised me to go to the facility to seek help.
So mare ne ke se mo nthong ya go ya ko yone, so ke a ya ko tleliniking ha ke tsena ke kopile fela gore ke batla go testa for HIV.
So I went to the facility and asked them I'm there to test for HIV.
So sister o nang thuse for go testa ka ke mo ke kry chance ke a mmolela gore okay ke na le bothata bo so then and referral ko the other nurse ya monna teng ko tleliniking ko start clinic.
So I met with a sister, I told her my problem, and then she referred me to another nurse.
That guy will anthusa am mpotsa gore bothata ke eng, ke a mo tlhalosetsa, am fa medication, am fa lemao, then am mpotsa gore okay this problem because nearly STI. So am mpotsa gore okay kopa o tle le your partner cause it ka nna ya mo affecta le yena.
Okay, I got help from a male nurse whereby he gave me a medication and injection, and then he advised me to bring my partner so that she may be checked against STIs.
So ke tla le yena ba itse ba mo thusa le yena kra medication, then that's the whole story.
I brought my partner to the clinic. They also helped her and gave her the medication, and that is my story. Thank you.
And one problem I notice jangle go clinic. Ne gona le ne ba berekisa motšhini o iwane fela wa blood pressure. So
when I went to the clinic, what I've noticed is that they have only one machine for blood pressure.
So tla no ya ka mo go emiwa o ya ka mo go emiwa ya ka ke wana fela ntwe ke boneng e le problem e.
So hence there ends up being a long queue. It's because they use one machine and there will be a lot of people. So that is the only problem that I saw.
Thank you.
Dumelang.
Good morning, everybody.
Na stomach experience as a base our clinicing like those that in this slow or young.
I have not experienced any bad thing at the facility.
But at work in Bonaki or some other day go traveling. I had some nurses babu when you know Tanalos Camonara Diluana like what's a HIV treatment.
What I've experienced is that I did not have any bad experience at the facility, but there was this one time I was at the tavern, and then I heard the nurses talking to each other saying that the lady who just walked in, she's taking HIV medication.
So that's why I feel
Hence, I feel that I will never attend that facility.
Thank you.
Thank you. Good morning, everybody. My name is Refile and I'm from Freiburg.
Bothata bo re nang le bone ko ditleliniking tsa rona tsa Freiburg ke gore go na le di long queue.
The problem that we're having at the Freiburg clinics is that we have long queues.
And mo dimo ga di long queue tsewa ke etla be le batho ba ileng gore ba tla go tsa di medication ga ba tla maitokong. Etla be le batho ba ileng gore ba tla go tlhaba di injection tsa bone or ba tsa di pilisi fela tsa body morning after pill or the injection tsa selo, and then the rest ke batho ba ileng gore ba tla maitokong.
On top of that, there are long queues whereby patients are coming there to collect their medications, but they are on queues. And then the others, they went there to collect to take their contraceptives. And then the rest, there will be others who came to see the nurses.
Yeah, so in na bothata bo botona because you find gore go manese a mabedi fela a berekang. And nako e nna ntsi e o tlang ka go ema ka yone, which is ga ene go le botoka ga ene le gore batho ba tlang go tsaya di-treatment tsa bone ba direlwe ga tekeng so se sa di-ATM. The CCMD, yes, because ke feel gore ya go fokotsa line and ya go dira gore batho ba leng gore ba tla go consulta serase ba lwala ba kgona go kry attention.
And at the same time, you'll find that there are 2 nurses at the facility whereby they have to help a lot of people. So my suggestion is that the facility they must have a CCMDD or they must have fast lane so that people who came to collect their medication so that they must not queue on the lines, they must go straight to the CCMDD, and then the nurses should attend the ones that are there for critical illnesses.
And another experience ke nnelang le yona ko tleliniking just recently ke gore ke fitlhile ko teng around 12.
The experience that I have recently at the clinic is just that I arrived around 12 o'clock.
And that time line e telele, and by the time re tla go thusiwa ne ba re bolella gore di facility ya tswala.
It was a long queue, and then by the time they were supposed to help us, they told us they're about to close the facility.
So the nurses started shouting at us that we came late and now they have to stay overtime for us and they're not getting paid for that. And they start telling us things that we don't want to, and they hurt us. Therefore, ke feel gore le nako e o fitlang ka yone like 12 o eme sebaka, you stay there for like 5 hours and then they tell you gore you are late, you should come early, and by that time you are in the same line le motho o eleng gore o sale a fola in the early hours around 7, so it doesn't really make sense. Thank you, ke leboga.
Good morning, everybody.
Lena ke dirisa facility ya Longley Park.
I'm using Longley Park facility.
I went there one time in December with the same problem ya my guy over here gore sometimes I will monna tshwanetse o ya wa go checka if ever gona le something is abnormal ka wena.
I went to Longley Park facility last year, December, just for a regular checkup.
Then I get to be honest, they were friendly. And ke kopane le nurse o na le friendly, o mphile di options tsa gore ke batla anthuse or ke tlhoka a male nurse gore a tle go nthusa. So because the way ona approach itse ka teng ke ile ka nna comfortable le ene ke mora ke rene there's no need for you to change the nurse, ke kopa o nthuse ke kgone ke tsamaye. So o bile an checka because ene ke ile go checka HIV and AIDS. Abang advice gore next time ga ke tle le my partner, because sometimes borre ba checka ka basadi ba tsama clinic go feta banna. So next time ke tsamele so that lena ha tla ke tlelene. So because ene ke na lene my partner ke metse ko waiting room, ke bile ka go motsara I checka rotlhe ba re cancela shapo ba re bolela ka prep gore go etsagalang e thusa ka eng. So re bile ra ba shapo. Nna ke a ke na bad experience ya clinic e ke dirisang for now, because it can be gore always re complain. Gona le rona ba bang ba re tsa sharp, gona le ba ba sa tseweng sharp according to their problems. So nkere nna ke kopa go ba uploada ke ba fe di roses tsa bone. a se manese a otlhe ko Longley Park a ka go tsayang sentle ebile a se manese a otlhe a ko Longley Park a ka sekeng a go tsaya sentle. So re tlhoka gore nako nngwe re ba fe that benefit of the doubt gore they are dealing le batho ba bantsi ka di-attitude tse ngata, and sometimes le rona re ba fa di-attitude as the patient. So na ke lebogetse thuso e nngwe le nngwe nkile ke a e kry-a go tswa mo go bone. Ke a leboga.
I went to Longley Park Clinic and then I was attended by a female nurse. She asked me if I was comfortable, if she could help me or she should refer me to a male nurse. The way that she approached me and she talked to me, I felt comfortable that she should not change, then she will help me. I went there to test for HIV and then we did all the processes and then she advised me that next time when I come to the clinic or facility, I should bring my partner along. And by then my partner was waiting for me outside. So she came in, we tested together, they advised us about PrEP, how to take it, and then we can never or we cannot complain about the services of the clinic every time. They have never done anything wrong to me and I've seen them work properly, so I give them a round of applause. Thank you.
Dumela. Thank you.
Leina la ka ke-
Okay, thank you very much, colleagues. Before I go for recommendation, I want us to give those dedicated healthcare workers a round of applause. This is what we want, and we would like to note those clinics so that we recognize those, and I will ask the department also to recognize and appreciate those healthcare workers. I'm very excited to hear that at least male patients are given a choice to say, would you like to be treated by a male? Because we know most of male, they don't want to go to facilities because they are treated by women and they are uncomfortable to take out their private parts and talk about their sexuality and all those things with the women. So I think in that case, Northwest, it's doing very well in those clinics. And if you can improve on that, I'm definitely sure by the next report we'll get more stories, more beautiful stories like this. This is what we want to hear. As I said earlier, for us doing this work, it's not to embarrass or just embarrass everyone and say the department is not doing well, but we want to assist each other to say, how can we improve our healthcare system? And we know that we have a problem of men not attending clinics. So if we get nurses and clerks who are dedicated to their work, like the one that was talked about in the video, to say she's very dedicated, she comes in time and make sure she comes early to the facility, make sure that everyone gets their file in time, and maybe people will be stuck on other consulting room. So if we can appreciate those people and also command or recommend other healthcare workers to do so, all the challenges that we are talking about will be very minimum. And the attitude, the bad attitude that we always complain about, it's something that can be eradicated, and it's something that we can be able to solve it. So going to recommendation is that the Northwest Department of Health should produce an annual report on the number of healthcare workers per cadre employed in each district, include the number of people and size of areas covered by these healthcare workers, year-on-year comparison from at least 2021, the vacancies and the cost of this post to the government. Fill all vacancies in 2023-2024 financial years. Not years, The Department of Health should extend facility opening times as per 2019 National Department of Health Circular, utilize appointment days and times to ease congestion, ensure filing system and maintenance in organized manner to reduce lost files, Open clinic grounds by 5 a.m. so that people can wait safely in the mornings. Ensure files are not required for facility pickup points. People living with HIV go directly to the pickup points to collect their art refill. Get more people living with HIV into external points to reduce congestion. PEPFAR should support in filling all vacancies at PEPFAR Operation Putuma support facilities in short term. Provide additional staffing for all PEPFAR supported sites to extend opening hours to 5 a.m. to 7 p.m. on weekdays. Fund adequate number of adherence staff facilitators to allow for the restart of adherence clubs. ORAM should immediately do an assessment to all PEPFAR Operation Putuma supports sites with waiting times over 3 hours and develop a specific plan for each facility that will bring the waiting time below 2 hours. Support the facility to organize and maintain support the facility to organize and maintain an organized filing system. Ensure files are not required for facility pickup points. People living with HIV go directly to the pickup point to collect their art refill. Get more people living with HIV into external points, pickup points to reduce congestion. So now I will hand over to Mary for art collection.
Ngiyabonga, Chairperson. The next group of issues is around ARV collection. The revised 2023 National Adherence Guidelines Standard Operating Procedure note that time constraints are a challenge to many people living with HIV and that efforts should be made to support people living with HIV with suppressed viral loads to receive extended refills and or be enrolled in repeat prescription strategies. Implementing this is vital to supporting improved long-term adherence. Ritshidze data reveals that a little improvement in increasing the duration of ART refills with 74% of people living with HIV interviewed by Ritshidze still receiving 2 month supply, and only 21% of people received a 3 or 6 month supply. This is up slightly from 17% getting a 3 to 6 month refill last year, but compares poorly to 64% getting 3 to 6 month supply in Mpumalanga, the best performing province monitored by Ritshidze. Progress towards multi-month dispensing in the Northwest also remains very low compared to 21 other PEPFAR-supported countries, where 80% of people living with HIV receive 3 to 6 months ART refill between October and December 2021. There's been an increase in people using facility or external pickup points. Of people living with HIV interviewed by Ritshidze, 26% collect this, at a standard medicine dispensing, with 46% collecting at a facility pickup point, 20% using the external pickup point, and 9% collecting at an adherence club. For those using standard medicine dispensing, 50% said they have not yet been offered the option to use a pickup point. All stable people living with HIV should be offered a range of repeat prescription collection strategy options as per the National Adherence Guidelines. Further, 61% of people living with HIV interviewed said that they would like to collect their ARVs closer to home if it were possible. There needs to be enough pickup points to decant people into, especially linked to peri-urban and rural clinics. A diversity of external pickup points providers is needed beyond private pharmacy networks, largely only available in urban areas. To service rural areas, small CBOs and early childhood development centers should be considered. Importantly, in order to be effective, repeat prescription collection strategies should make ARV collection quicker, easier, and more satisfactory for people living with HIV, yet this is often not happening. 39% of facilities monitored said that people using facility pickup points must collect files, take vitals, and see a clinician before getting their parcel. 59% of people living with HIV also affirmed this problem that adds to the delays at the facility. While it should take less than 30 minutes to collect your parcel and go, 34% of people interviewed said it takes up to an hour, 18% said it takes up to 2 hours, and 33% of the people said it takes up to more than 2 hours to collect your parcel. Once enrolled, every effort should be made to keep people continually active. Reassessment should take place at each clinical consultation to understand if people living with HIV are satisfied using their pickup point or a club. People living with HIV who are not satisfied or very satisfied, as reported by 12% of people using the facility pickup point, should be offered a different option that better meets their needs. We are going to have a few recorded stories.
Nna ke berekisa Tsholofelo Clinic nna ke no di-ARV ane ke di nwa sentle tsone di-ARV tsaka ga ke di tlodise so ke ne ntse ke di tsa ko posong dijaganyana tse di fetileng tsele so itse ga ke re ke a ya ko posong ke go tsaya treatment eo ke ba mpolelela gore ke boele ko tleliniking so ko tleliniking ga ba ntlhalosetsa for gore ke boele ko go bone ene bothata ke eng ke tlile ba mpha di-treatment ela be ke bone ha ke itumelela go khutlela ko posong ka gore ko posong ha gona stress se ngata o tsena fela o bontsha o shupetsa appointment ya gago ba bontsha dipilisi tsa go ba go fa tsone bo boa.
We have one community story on the issue.
Dumelang bagolo.
Good morning, everybody.
O buang ke Dorcas Mogale from Bapong, Moses Kotane.
I'm Dorcas Mogale, I'm from Bapong in Moses Kotane.
I have a friend o tsang di-ARV but a nna mo motseng wa Bapong.
I have a friend who's taking ARV medication who lives in Bapong.
But this person ga kgone go tsa di-ARV ko tleliniking ya Bapong o di tsaya ko Swartregens.
But she's not able to take the medication from Bapong. She takes them from Swartregens.
Why are they go Bapong?
Why is she not taking her medication from Bapong?
It's because ko tleliniking ya Bapong ga bana sephiri go fetsa o testa ba bua ka wena.
It's because at the Bapong clinic, when you just tested for HIV and AIDS, they disclose your status.
So this person ga di treatment ya e fedile a sena tšhelete ya go ya ko Swartregens because o berekisa 200 rand go ya Swartregens.
When her medication is finished and then she's supposed to go to Swartregens and she does not have money, and then at the same time she spends 200 rand from Bapong to Swartregens.
O ya ko tleliniking ya Bapong go kopa medication then ba motima.
She goes to Bapong clinic to request for the medication and they refuse.
Then motho ga sena tšhelete ya go lata treatment go ra gore wa defaulta cause a ka ska ba kgona lata treatment.
So if she does not have the money to travel from Bapong to Swartregens, it means that she is defaulting because she does not have any medication to take.
Thank you very much.
Thank you very much. Now we go for recommendation. The Department of Health should extend and implement ARVs refills to 3 months by the end of September and 6 months by the end of September 2024. The Department of Health and Oram should ensure all people living with HIV are offered a range of repeat prescription collection strategy options and those enrolled at RPCs are active. Ensure that reassessment of RPCs options takes place at each clinical consultation to ensure people living with HIV remain satisfied with their RPCs. Ensure all facilities implement the 2023 adherence guidelines standard operation procedures with fidelity, including ensuring facility pickup points A one-stop and very quick art collection only. Visit in under 30 minutes. No need to go to the registry, collect folders, see clinicians, and etc. Ensuring that the re-establishment, implementation of quality adherence lab, including group facilitation component, increase the number and types of external points to ensure urban, peri-urban and rural clinics have external pickup points. Ensuring people going back to clinics for their RPCs receive the script on the same day, if clinically well, to ensure no necessary additional facility visit with effective recall system to action any abnormal results or elevated viral load. PEPFAR should monitor and hold accountable DSPs to implement 2023 adherence guidelines standard operation procedures with fidelity. Let's add continuity again. Okay, so it's Mary, it's Ludik, eh?
The next group of issues are on art continuity. PIL-HIV lead complicated lives and may well miss appointments and even miss taking some pills. When they do, meeting them with support when they return to the clinic helps ensure long-term adherence, but often, when people living with HIV and key populations return to the clinic, they are treated badly, leading to people disengaging from care. A differentiated services approach is required for people living with HIV who are re-engaging in care. Some will require intensive clinical management, including advanced HIV screening and management. Some will require psychosocial support in the form of quality counseling and group support options. The majority need it to be made easier to collect treatment. These people should be offered MMD and should be assessed and offered access to pick-up points or adherence labs as quickly as possible. Implementing 2023 re-engagement clinical and adherence guidelines are vital to support improved long-term adherence and retention. ORAM should support the remaining 31% of facilities and any others in the district in training, mentoring on the changes in the new 2023 adherence SOPs. Ritshidze data revealed that out of 1,072 respondents, only 49% of people thought that the staff were always friendly. Am I right? Oh, okay. I beg your pardon. Ritshidze data revealed that out of 1,072 respondents, only 49% of people thought that the staff were always friendly and professional. Northwest was one of the lowest performing provinces on this indicator. 51% of people thought that staff were only sometimes or never friendly this year. This graph shows data across time with worsening in staff attitude over the last year. The province must improve to ensure all people living with HIV, key populations, and other public healthcare users are treated with dignity, respect, and compassion at all times. It is also important to note that because Ritshidze interviews take place at the facility, people who have already disengaged from care due to poor staff attitude, some of who we will hear from in our community stories will not be at the facility interview. Out of 62 people living with HIV who had missed appointments, only 23% said the staff were welcoming when they came to collect ARVs if they had previously missed a visit, with little change from last year. 29% said that staff still send you to the back of the queue the next time you come in. Yet, according to the South African National Welcome Back Campaign Strategy and the National Adherence Guidelines, people should not be sent to the back of the queue or made to wait until the end of the day to be seen. A returning patient should either be seen in a separate stream or take up the next queue space. Further, the 2023 adherence guidelines SOPS says, retaining or re-engaging patient should not be made to wait until last to see any service provider should join the patient queue on the same basis as all other patients. No punitive actions may be taken by facility staff. While most people did not report transfer letters being a challenge, 82 people interviewed by Ritshidze had been denied access to services for not having a transfer letter across 11 facilities in the last year. This represents 8% of public healthcare users interviewed, and given the most people interviewed are unlikely to have attempt to transfer services, it continues to point to a larger problem regarding the communication and policies regarding transfer letters. A reminder that transfer letters are not required in the guiding principles of re-engagement SOP, which states, if a patient comes from a different facility, it is critical that the patient be provided with treatment on a day of presentation. While referral letters are helpful, a patient cannot be required to leave the facility without treatment. 80% interviewed by Ritshidze had been denied access to services for not having an identity document across 11 facilities over the last year, representing 7% of all people interviewed. Again, given most people would not have had a challenge with IDs, it points to a wider problem. Also, as Ritshidze interview takes place at the facility, people who have already disengaged from care due to challenges accessing a transfer letter or not having an identity document would not be at the facility to interview. Psychosocial support is another critical element to ensure long-term retention. Not all people living with HIV interviewed know that psychosocial support is available. Further, a full package of psychosocial services are not yet available at every clinic. A full package of services should include provision of individualized quality-assured counseling to patients, peer-led patient navigators acting as bridge between clinicians and patients, map networks of referral services, optional support groups, and food parcels. As part of psychosocial support groups should also be linked to each public health facility that are critical to provide counseling and support services to people prior to testing, post-testing, pre-treatment, and those struggling on treatment or re-engaging in care after treatment interruption. Treatment literacy also improves art continuity as people understand the importance of starting and remaining on treatment effectively. Of the 527 people living with HIV surveyed, 98% had received a viral load test in the last year, and 90% reported that they knew their viral load. However, there remain significant gaps in knowledge and treatment literacy. Only 77% agreed with the statement, having an undetectable viral load means the treatment is working well. And only 62% agreed with statement, having an undetectable viral load means a person cannot transmit HIV. Possibly the 10 facilities shows here actually had perfectly scores where all PLHIV understand why an undetectable viral load is good for their health. This includes all sites monitored in Ngaka Modiri Molema and most sites in Dr. Kenneth Kaunda. Yet all sites monitored in Bojanale, far fewer PLHIV understood that an undetectable viral load is good for your own health. This includes just 3% of PLHIV at Lethabile CSC, just 7% at Bapon CSC, and just 20% at Buitukon Clinic. Further 6 sites have perfect source where all PLHIV understand why an undetectable viral load is good for ensuring you cannot transmit HIV, including all sites monitored in Ngaka Modiri Molema. Yet at the sites in Bojanala and Dr. Kenneth Kaunda, far fewer people living with HIV understood that an undetectable viral load means you cannot transmit HIV. This includes just 3% of PLHIV at Lethabile CSC, only 7% at Bapon CSC, and 15% at Buitukon Clinic. Overall, only 85% of those surveyed said a healthcare worker had explained the results of the viral load test. It is critical that healthcare workers explain people's viral load test results in a timely manner and ensure that the message that an undetectable viral load improves your own health and prevents transmission, which is you equals to you, is better communicated. Now we move to recorded stories.
Ke tsa treatment ya HIV ne, and then ke tsa treatment ya HIV, I decided to ga ke tlo etsa for mogwasi. The reason being, ge ba le ko di-taverneng ko, motho wa teng o tla ba a go supa. Maybe o firiwa ke motho a montsi. Gape re na le di-bomb, ba re ke bomb. Ska bua le ska mmona riana o tsa outloko ba ibitsa outloko ga go take di ba re ke outloko. So the reason ke sa tlang fa it's dead e polelo re tla ke le go Moses Kotane batho ba go Moses Kotane le ge ba na le dilo tsa bone o mongwe le mongwe o na le mathata a ge batho mara those people ba ile go fa service e o e tlhokang ga o feel gore ga ba go berekela o na le freedom ya go namella o ye ko managereng o bo mmolella so se mmolellang fa o ka kopa manager o ka se mo kry unless go na le system one fa o eleng gore ge dilo di sa tsamaye pile be go buiwa lene ke eno e le gore batho ba botlhe ba getse ba tlhoka thuso serious ba ya kwe rakgadi ge ba ntse ko di-taverneng kwa motho wa bua gore le nno le kwala di-suggestion box na gona for tsenang fo teng ra dintsha dilo tseo tsa lona re tsenya dilo tse re batlo di tsenya so nna ne re sa tlhaloganye gore re itshenyetsa nako o tlhola ntse ra kwala gore bathong ga re treatiwe sentle yana cause go a tshwana ko kwala complaint e sene ke e kwala mantsiboa ba kopana ba e ntsha ga ke kgone e berekisa tleliniki e ke gaufi thata le yone ga ke nne kgakala thata le tleliniki mara fela ka maitshwaro a batho ba ba berekang fa towards rona bakudi ga ke kgone nkampe ne ka tsaya tšhelete ya bofelo ya bana ya di-grant cause nna ke bereke ke surviva ka tšhelete ya bana ya di-grant ke tsamaye ke Moses Kotane ene o gopole gore bana ba ya sekolong phakela nka se tsoge ka nako e ke tsogileng yaka ga ke tla kwana fa ga ke tla ke kgone go tswa ka 4 ke itse gore ge ke fetile ka buka line at least ge re bo ma 6 ka tsamaya ko fete ke prepare bana ba sekolong ko Moses Kotane ga o ile o a itse gore ge re 10 o tlile gae
nna ke berekisa Tsholofelo tleliniki ke tletla ke ema ko tleliniking ha ke eme ke go kry service ka bo 80 kwa e le gone ba bulang ba tla ba re tsaya ba re tsenya mo jarateng ha ba etsa go re tsenya mo jarateng ba tla ba re fa dipilisi tsa rona mare ha o na bothata ke gore ha o na le bothata o kopa gore ke kopa le nthuse ka dipilisi tsa di-pain or tsa di-eng ha o di kry ha ba go fe tsone ba go bolela go di fedile treatment ka kgale ntse ke enwa sentle mare yaanong ga ga betsa go ntsha madi ke tsa madi ka October ha ba fetsa go ntsha madi ka October ha ke ya kgwedi e latelang ga ba tshupetse di-results tsaka
ke sebedisa Tsholofelo tleliniki ke tsa treatment ko Tsholofelo tleliniki basebetsi ba teng ba sebetsa mare ba root nna ke batlo go bua maaka ba root ga ba itse go treata di-patient tsa bone sentle ha o tla ko go bone sometimes o tla ba o kry-a motho a se mo di-good mooding o ipotsa gore mare yaanong ha o tla ko tleliniking for thuso gore o kry-e thuso ke teng ko re sendetsweng teng gore re tshwanetse ke gore re kry-e thuso teng nou yana ke di-date tsa di-treatment ra ya ko ditleliniking re ile go tsa di-treatment ga wa tshwanela go misa date ya gago ka 1 day fela o tla be o bolelelwa go ba go shouta ga o misitse treatment ya gago ke tsaya treatment ya ntho ya AA ke ya HIV the time fela ga o misitse treatment ya gago o tla be o fiwa date e nngwe sometimes ga o na tsone ke tsa di-last tse di setseng tseo like no yana tse di setseng tse ke na leng tsone ke tse di setseng tse di bikinyana since from 19 April ke misitse date ya ka 19 April since ke emetse SMS ha ke ya ke nna ke leng phosho ha ba kgone go admita gore ke bone batho ba ba leng phosho last time ntate o mongwe o ne a shoutana le mme o mongwe until ba mo dudisitse le gore le ene o mositse date yalo ha ba fetse ba mmolelela gore o tlo go tswa le bone ha ba chasa nagana motho o wa kula o na le siki tse dingwe tsa gage ntate o modimo since a dutse the whole day ko tleliniking a emetse 4 since a tlile vroeg
ke tsa treatment ya HIV ne and then ke tsa treatment ya HIV I decided to ga ke tlo etsa for mogwasi the reason being ge ba le ko di-taverneng ko motho a teng o tla ba a go supa maybe o firiwa ke motho a moitseng gate re na le di-bomb ba re ke bomb ska bua le ska mmona riana o tsa outloko ba editse outloko ga go teke di-ARV ba re ke outloko so the reason ke sa tlang fights that ke ipolelelo re tla ke ikele ko Moses Kotane batho ba ko Moses Kotane le ge ba na le dilo tsa bone o mongwe le o mongwe o na le mathata a ge batho mara those people ba ile go fa service o e tlhokang ga o file gore ga ba go berekela o na le freedom ya go namella o ye ko managereng o bo mmolelela so se mmolelelang fa o ka kopa manager o ka se mo kry unless go na le system 1 fa o e leng gore ge dilo di sa tsamaye pile be go buiwa lene ke ene e le gore batho ba botlhe ba getse ba tlhoka thuso serious ba ya kwena rakgadi ge ba ntse ko di-taverneng kwa motho a bua gore le nne le o kwala di-suggestion box na gona for tsenang fo teng ra dintsha dio tseo tsa lona re tsenya dio tse re batlo di tsenya so nna ne re sa tlhaloganye gore re itshenyetsa nako o tlhola ntse ra kwala gore bathong ga re treatiwe sentle yana cause go a tshwana ko kwala complaint e sene ke e kwala mantsibua ba kopana ba e ntsha ga ke kgone e berekisa tleliniki e ke gaufi thata le yone ga ke nne kgakala thata le tleliniki mara fela ka maitshwaro a batho ba ba berekang fa towards rona bakudi ga ke kgone nkampene ka tsaya tšhelete ya bofelo ya bana ya di-grant cause nna ke bereke ke surviva ka tšhelete ya bana ya di-grant ke tsamaye ke Moses Kotane ene o gopole gore bana ba ya sekolong phakela nka se tsoge ka nako e ke tsogileng yaka ga ke tla kwana fa ga ke tla ke kgone go tswa ka 4 ke itse gore ge ke fetile ka buka line at least ge re bo ma 6 ka tsamaya ko fete ke prepare bana ba sekolong ko Moses Kotane ga o ile o a itse gore ge re 10 o tlile gae
nna ke sebisa tleliniki ya Grace Mokgomone ke nwa treatment ya HIV and AIDS ne so treatment re tholang ko tleliniking ha e good nix because sometimes o fitile date like today o tlampe ile today we are outside ba tlo bolela dipuo and then ba fa ditaba tse ngata and stuff ba go bolela ba tla go remove mo tleliniking and then ba ka se tlo clear thuso anyway wa bona ba tla ba bolela gore eng ba bitsana mo tleliniking ba gwathang the whole clinic ofela ba tla ba kenya auto ba bontsha everyone wena khalosa tleliniking khalosa etseng which is ntho right because ntho ya HIV e privacy e fela between na lwena nurse so ha o tsa montla la tsa mo nurse ntse ding o etsa eng cause o tsa mo bolela batho ka ofela ha o na le bothata ba bua ka wena ka ofela ba o shout ha ba bua lena like hantle bo fe treatment hantle ba bua le sometimes a ke yo mo kana wa bona ke na le place ya go na le kwa e go sometimes ke go guy and go tleliniki tsa ka kwa di tshwana tsa ka ba tlo go bolela gore e tshwanetse go tlile ka remove and which is how do go go ya fela ka o chaka o itse like lucky ya ke last ke ile ke re kopa treatment before ke tsamaya cause ke lo dula ba re se ka bo ma 2 months go ka ba re a ona ba ka fa treatment ngata jwalo wa bona ke be ke re na re nna ntho ke irang ko ke le baka la go ke lo sebetsa sa nakonyana for 2 months so ke tla go tlana ko eo sister yo ke mpore go fa dipilisi tsa kgwedi 1 so o tla bona ko tswa jwa
ga ke khutle ga bang ka setsa ga ke bopola ke bolela o ke mo bitsa ka lebitso ke re sister e feng ditse somewhere ga ba re he ga ona like motho o senang diphoso a ke re diphoso wa itse o ka feta date ya go fandaga go sane wa ya mara wa tlampe go shauta go sa ba fetisa le beke go batla at least maybe motho o mongwe like a o okametseng ditleliniki a tsamaye mo ditleliniki a kgone go bona go ditleliniki nna ke sebisa tleliniki ya kerese mogomone ke nwa treatment ya HIV and AIDS ne so treatment re ke tsamaya tleliniki ya Ramatlabama tleliniki HIV positive as an HIV positive person re na le go kopana le sosele sa gore go ditleliniking ga ba re treat sentle and then ne ke defaultile by the way a ke boela ko tleliniking I was expecting gore ke go kry-a treatment ele ya gore ke a omanyiwa and all the sisters were friendly le go omana just that they advised me gore no so se dirileng ga se sone you know we always complain ha re bona dilo tse di maswe but when we don't ha re bona tse dintle ha re fane ka compliment so ke feelile gore it deserve a compliment mmereko ke boneng ba o dira you know what I saw that day le nna ke ile ka lona go nne le for me gore ke feletse ke ba compliment go nne le that thing ya gore body the files are missing matsapana a tsa ka nako go sister Sibu it was beyond none to suffer after taking my blood doctor itlile ha gona file patient ntse batliwa o tlogetse ntha sister re feditse nna le wena aba go attend go tladiwa those papers tse tsa madi a go batla file and he came back with it so I heard the complaints na before at clinic ne so gora gore yana being there o tlise a change and ke lemogile gore it's not only him because le yana wa bereka ke feelile that thing ya gore because ona le that energy he's friendly to everybody the patients and the nurses e ba fa sosele because ke bone ba dirisana so if this thing e ka diragala le mo ditleliniking tse dingwe ya tswela ya diragala I don't think gore ga gonna le mathata a re a face mo ditleliniking every day
We're going to have 4 community stories.
Greetings, everybody. Dr. RSM.
My name is Khomotso from Freiburg. A lot is happening in Freiburg. We had 3 clinics, but now we have another one at Color Block.
Experience e ke na leng yone ka clinic e one e leng gore batho ga ba complaina thata ka one and ke ntse ke e dirisa ke tsaya dipilisi tsa ka ko teng tsa prevention from pregnancy.
There's amongst those 4, there is one clinic that we are having a problem with. Most of the people do not attend that clinic. I used to go there and take my pills while I was pregnant. It's located in Huhudi.
Manese a kwa ha itse go treata batho at all, ha ba itse go treata batho sentle at all.
The nurses at that facility, they do not know how to treat people at all.
O tlo tsena early o expectile gore wa go boa ka nako so that o kgone go dira mabaka mangwe ba go dulelana ba ntse ba go botsa gore o tlile go dira eng mo wa boa mathata ga go keng.
You'll go to the facility early in the morning expecting that you'll get helped and then go back home in time. But they will ask you questions that what are you doing there? You're coming back now and then.
And nako ba go botsa mo pele ga batho and wena maybe o tlile go tsaya dipilisi tsa gago tsa ate.
They ask you those questions in front of the people and by that time you are there to collect your art treatment.
There was even a time last year mo eleng gore ke experience itse gona le mme mongwe a ile ka ngwana ko tleliniking.
There was a time around last year there's a woman taking a child to the clinic.
Ngwana wa a fitla tlhokofalla teng ko tleliniking manesa le teng ba sa thusi ba ntse ba re ba batla thusa batho ba bang ba ile khaleng ba tlile mara re khona go bona gore this thing is an emergency ngwana o tlhoka thuso no yana.
By the time I attended the facility, there was a woman who brought the child there. We could all see that the child needed an emergency, but they said they will help the people who went there first, then they will attend the child after, whereas the child ended up passing.
we as the community, we tried to re lwantshane le this thing ya manese ako huhudi gore why ba le yana kgatlhanong le batho ba bone ba sa ba thusi ka lerato ba kreye thuso e ba itletseng ko tleliniking ewa.
We tried as a Huhudi community to intervene with the facility and ask the nurses why are they not helping us.
They were very rude. Ga ba re naya dikarabo tse re di batla ba fela kwa ha ba itse go bua le batho.
They are very rude. We did not get the answers that we were looking for as a community.
So, khona le kliniki e nngwe e ko gateway e ko toropong. Imagine batho ba tswang ku Huhudi ba tsamaya all the way ba golo ba tsamaya all the way go ya ku kliniking e ko toropong ba tlogela e mo lekishini just because ga ba kreye treatment e siameng from manese a mo kliniking ewa.
The elderly people from Huhudi, they walk from Huhudi to town to
go kreye thuso ku kliniking ewa.
Or there's a clinic at town, so elderly people walk from the location to town so that they can get a better treatment from the nurses.
Yeah, so ke ne ke kopela fela gore go nne le di campaign di skala batho ba ska neglectiwa ko Vryburg. Di campaign tse di tlhole di tshwariwa ke bona gore batho ba ntse ba interviewa mo le ba budiwa gore go yang mo ditleliniking tsa bone le rona re ikopela ko Vryburg gore dilo tse dintsinyana di re fitlhelele so that re kgone go kreya thuso cause ha ile gona fela batho ba mo community ga rena backup ga rena batho ba ileng gore ba ka felletsa ba gatelletse batho ba gore ba bue ba kgone go thusa batho ba dire ba tsaye di duties tsa bone ba di dire sentle.
My plea is that we as Vryburg people, we should have campaigns just like that I've seen here in the monitors, people being interviewed, being asked how are they being treated at their local clinics or facilities. That is our wish.
And the other thing ke kopang ke gore ke kopa go bala fela mo ko ditleliniking tsa rona re create a safe and conducive environment for batho ba ileng gore ba tla ka ba rotlhe re tla ka maemo a different ba bangwe ke ba disabled o ka fihlela motho a go dula sebaka ko letsatsing e le gore pleke ga shapo o dula ko ntle mo seraming sena ba go bolela gore line e telele fola kwa at least ha ile gore batho ba o batla go nne le ba ileng gore ba go tsewa ba disabled ba fole that side ba kgone go thusiwa because ra bona gore ba ka se kgone go ema sebaka like rona batho ba re tlang go tsaya dipilisi fela. And then le ba golo ba ileng gore ba na le bodi high blood ba ska emisiwa sebaka mo letsatsing like ke tlhole ke bona go diriwa a nne gore ke priority a ba prioritiziweng ba belwe di like nna di thini tsa bone fela kwa ba tende mo le ba tsene ba kreye thusa bone ba tsamaye ba kgone go boela gae. And then rona ba ileng gore re kgona go ema sebaka re ka ema re kgone go kreye thusa rona mare a ba ileng gore ba na le ditlhoko tse di special ba thusiwe ba kgone go tsamaya.
And one other thing, my plea is that when the elderly or the disabled people attend the clinic, they should be given chairs or they should be given a specific place where they will be helped instead of them being sitting outside in the sun and waiting for a very long time.
Yeah, and the other thing, ke kopa gore go mobiliziweng di community tsa kona le di municipality to act against whatever se diragalang mo di tleliniking tsa rona. Ke ikuela mo go Ritshidze gore gape they should lobby against all these people. Ba itse gore batho ba na le di rights ha ba tla mo tleliniking ba na le di rights le bone as much as manesa wa le bone ba na le di rights le rona re na le tsone and then ba re emela ba re thusa gore re kgone go kreya thuso e phepa e tshwanetseng ke gore re kreye ka leboga.
And one other plea that I have is for Ritshidze to mobilize so that they can go to the facility and ask the facilities to fix the problems that they are having of people who are disabled and who have special needs to be helped in time and friendly so.
Dumelang bagolo.
Greetings everybody.
Nna ke emetse community ya Bethane.
I'm from Bethane.
Ke kry-ile di-complain because HIV patients tsa ko Bethane ga ba kgone go nna free go ya tleliniking.
I got the complaints from the community that patients who are HIV positive cannot be free to attend the clinic.
Because ge ba tsena ko tleliniking batho le ge motho a tlile tleliniking a sa tlo tsa dipilisi e le koko sta itse gore ngwana a mang wa lwala ngwana a mang wa lwala o HIV positive.
They do not feel free to go to the clinic because whenever they go to the clinic, everybody knows about their statuses.
Because ba labelwa,
because they are being labeled,
ba treatiwa differently,
they are being treated differently,
le di-card tsa bona di na le sticker se se green,
and their cards have green stickers.
and most of the time ba default.
And most of the time they default.
And point e nngwe e ba e buileng ba kopile gore ba buile gore ge ba tla tleliniking ba tshwanetse ba tle le di-bag, o female or o male.
Then they were asked to bring their bags to the facility whenever they go there. It's either you are a male or female.
Beke eo e tshwere container ya dipilisi go bontsha gore o ntse o nwa dipilisi, ba rotle ka yona ka di-container tse go bontsha gore o nwa dipilisi tsa gago.
That bag should contain the containers of the medication that you have been taking as a proof that you have been taking your medication.
So ga ba feel comfortable le free gore ba ye ko tleliniking.
So they do not feel comfortable to go to the facility.
Ke a leboga.
Thank you.
Dumelang bagolo.
Greetings everybody.
Nna ke tswa ke le ko Bapong.
I'm from Bapong.
Ke ile ko tleliniking ya Bapong ka 2009 kilo tester.
I went to Bapong Clinic in 2009 to get tested.
Ke boeletse ko teng 3 times ha ise ke kry di results tsa ka.
I went back 3 times and I did not get my results.
Ka ya ko tleliniking ya ko Tuelacht.
I went to Tuelacht Clinic
ka 2010.
In 2010,
then ka kry treatment ko teng,
and then I received my treatment there.
And then ka 2014 ke ge ke tshola ngwana.
In 2014, I had a child.
And then a le negative.
And she was negative.
Because ne ke kry ke ja treatment sharp.
Because I took my treatment during my pregnancy.
So khona yanong a ke bereki and my husband ila tlhokofala ka 2017.
And now I'm not working and my husband passed away in 2017.
Treatment e re kreang ko Bapong ke tshaba go boa ke kope transfer gore ba nthuse.
The way that they're treating me at the facility, I'm afraid to go back to ask for a transfer later because they're not treating us well.
Ke kopa thuso gore le re thuseng ka di campaign because re nna ko magaeng a serious.
My plea is that you should help us with the campaigns because the way that we are being treated is not okay and we live in the far rural deep areas. Thank you.
Dumelang bagolo.
Greetings everybody.
Nna ke nna Ana Mogwase go tswa ko Bapong Moses Kotane.
My name is Ana Mogwase from Bapong. Moses Kotane.
Ka March ke bile ka ya tleliniking go Bapong.
In March I attended a clinic at Bapong.
So ga ke tsena ko teng ba ntha ba re viral load wa ka e ko tlase.
So when I arrived there, they told me that my viral load went up.
And then ba ntsha madi.
They took my blood.
And then the result ga di boa gape ja di re viral load wa ka e ko tlase.
When the result came back, my viral load was down.
Last month I got 15th of June.
Last month on the 15th of June,
I
went back to the clinic
treatment
to collect my treatment.
Reception.
When I got to the reception, the reception lady took out my file. And she took out the particulars from the file. After looking at them, and another sister came in.
So also a reception sister.
The reception lady was explaining to the nurse.
The result is a meo di viral load wa go santse le ko tlase gape so ga ke tsore ga go ntse ana go etsiwa yang.
The reception lady explained to the nurse that my viral load was still down, so what are we going to do?
Sister o le ile araba usole. A mmolela gore wa itse gore keng. Ga re tle go nna re tshameka ka dipampiri tsa ko lepo. Re tsa batho madi ba sa no dipilisi tsa bone sentle.
And the nurse's response was they are not going to play with the papers from the lab while people are not taking their medication correctly.
And na ke no treatment ka sentle.
And I take my treatment correctly.
Ga gona letsatsi le ke tudisang go na treatment
I do not miss a day.
So sene ke se ipotsa gore e le gore go bone ga gona so se ba ka se etsang.
So my question was, is there anything that they can do?
Maybe go ntsenyetsa appointment ko tleliniking.
Maybe to put in an appointment for me?
For a doctor.
To see a doctor.
Ke a leboga.
Thank you.
Thank you so much. I realized Hore Meg kept on saying her viral load is down, whereas she wanted to say, Hore, every time that she goes to the clinic, her viral load is high. Hence, they were testing her time and again for her viral load. And now, nobody's suggesting any alternative or changing her medicine or changing her regimen, but they're blaming her, accusing her of not adhering properly to her treatment, which is not fair. Because imagine yourself as a person who's adhering to your treatment, taking it properly every day, but you are accused of not taking it. Eventually, it might discourage you and motivate you to disengage from your treatment. So this is one of the issues that people living with HIV face in the facilities that we use. We're going to have recommendations from the chairperson.
Yeah, the recommendations are the Department of Health should ensure staff acknowledge that it is normal to miss appointment and to have treatment interruptions. People living with HIV returning to care after late, missed scheduled visit, silent transfer from one from another facility or treatment interruption should be welcome. And ensure the OH staff treat people in dignified and friendly manner and investigates any reports of poor attitude raised by Ritshidze and take disciplinary actions where appropriate. Send communication to all sides highlighting that no person living with HIV to be sent back to the queue of if they miss their appointment as per the Welcome Back campaign strategy that says people returning to care should be triaged. Ensure transfer letters are not be required for ARV continuation or restart. Any reports where treatment is delayed by requirement or transfer letter should be urgently investigated and disciplinary action taken where appropriate. The Department of Health and ORAM should implement 2023 adherence guidelines standard operation procedures with fidelity, including ensuring that every person starting out is provided with good quality fast track initiation counseling session 1 at our start and session 2 after 1 month on ART. Taking first viral load as early as possible to ensure providing earlier adherence intervention, support and earlier access to longer treatment supply at more convenient locations. Actioning and evaluated viral load without delay, including funding the setting up effective abnormal results, recall systems, and providing quality enhanced adherence counseling when appropriate. Actioning a suppressed viral load without delay, focusing on immediate assessment, offer, and enrollment into a repeat prescription collection strategy of choice for a month after viral load taken. All facilities implement 2023 re-engagement algorithm. Yeah, slow. Including appropriate differentiated services to people living with HIV. Ensure Department of Health and ORAM staff provide accurate and easy understandable information on treatment literacy and adherence, and the importance of undetectable viral load through consultation, counseling, and outreach. Ensure that treatment literacy information is provided at health talks each day at the clinic. Ensure that Department of Health and ORAM staff explain viral load test to result to the people living with HIV properly and in a timely manner. ORAM should ensure ORAM staff acknowledges that it is normal to miss appointments and or have treatment interruptions. People living with HIV returning to care after late missed scheduled visits, silent transfer from another facility or treatment interruptions should be welcome. Ensure ORAM staff treat people with dignified and friendly manner, and investigate any reports of poor attitude raised by Ritshidze and take disciplinary hearing where appropriate. Support with training and mentoring of Department of Health staff at facility level on revised 2023 re-engagement clinical and adherence guidelines. PEPFAR should fund an expansion of people living with HIV, key population-led treatment literacy efforts across all provinces through training, education, and localized social mobilization. Before I hand over to Londi, I just want to comment also again the clinic that welcomed the sister back to the clinic and in a friendly manner. That is what we want, but also there are still gaps that we need to fix. And I think all of us were listening here when the old man was made to sit at the back of the queue until they are done. We cannot continue to accept such behavior. But also, I would like to ask the officials who are here from the Department of Health to assist the lady with the viral load that continues to go up while she's taking her treatment. It might be number of issues that are affecting her viral load. Sometimes we know that there is treatment resistance that is happening in the body of a person. Maybe some of the ARVs are no longer working well in her body. That's why the viral load continues to go up while she's taking a treatment. There are a number of issues that might be like that. In some cases, it could be she has a chronic illness that is still hidden in her body that needs attention. So I think if you can take up that case, it will be really appreciated. So now I will hand over to Londi with key populations.
Thank you, Chairperson. I cannot recall introducing myself. My name is Londiwe Kozwayo, and I'm the key population organizer for Ritshidze, and I will be taking you through the issues that are affecting key population. Public health facilities are the entry point for many key populations into the health system. Therefore, it is critical to ensure a friendly, respectful, safe, and confidential environment for all, with the services that cater for key population specific needs. Yet, despite sensitization trainings and retraining efforts, disrespect, ill treatment, and dehumanization of key population remain the widespread challenge. Key populations who are treated badly, humiliated, fear their safety, or even refuse the entry will inevitably not come back to the facility. Ritshidze data revealed that at public health facilities, only 34% of gay, bisexual, and other men who are having sex with other men, 22% of people using drugs, 45% of sex workers, and 30% of trans people reported that the staff are always friendly and professional. Where the attitude of clinic staff have become unbearable, some people have stopped going to the facility altogether, including for HIV, TB, and STI testing and treatment. Disgraceful privacy violations continue to occur that destroy people's rights to privacy, to make clinics feel unsafe and uncomfortable to be in. This year, 33% of GBMSM, which is men who are having sex with other men, 38% of people who are using drugs, 42% of sex workers, and 48% of trans people did not think that privacy is well respected at clinics in the Northwest. The majority of key populations interviewed did not feel comfortable going to the facilities. In order for key populations to access health services, and particularly key population-specific services, spaces are needed that feel private enough to disclose that you are a member of a key population group without fear of being judged, abused, or harassed. Shockingly, significant numbers of key population reported being refused access to services in the last year just because someone uses drugs, or either is a sex worker, or being part of the LGBTIQ+ community, including 5% of GBMSM, 11% of people who are using drugs, 14% of sex workers, and 6% of trans people who we interviewed. This is absolutely unaccepted and goes against the Section 27 of the Constitution. Where key populations do not find continue to suffer the daily indignities of using public health systems, specific services remain unavailable for the most part. Ritshidze data reveals that a low proportion of facilities provide services for the key populations when asked generally. It was only 50% of facilities reported providing services for GBMSMs, 38% for people who are using drugs, 44% for sex workers, and only 44% for trans people. However, when we deep dive into the specific services which are on offer, it becomes clear that very few services are actually available. Key populations can't always access basic prevention tools like condoms, and more especially lubricants. Lubricants, for an example, are only freely available in only 25 of the facilities that we monitored. And in those sites, too often the lubricants are put in spaces where staff and community members can see you collect them, like at a reception or in a main waiting area where everyone will pass through to get into the facility, and they are more likely to see you. Only 44% of GBMSM, which we interviewed, 31% of people who are using drugs, 38% of sex workers, and 43% of trans people using public healthcare facilities said that they could access lubricant. And far fewer said that the staff were respectful when they tried accessing lubricants, or that they could always get enough. Comrades here today, please put your hands up if you can regularly find lubricants in your clinics. I'm talking to the KPs. Can you find lubricants in your clinics? I can only see one person who agrees, so what about the others? That's the reality. Not everyone can access basic commodities in the clinic. Not all facilities prioritize offering key population PrEP despite it being available in majority of facilities monitored by Ritshidze. While covering a wider and different sets of sites, only 28% of GBMSMs, 5% of people who are using drugs, 17% of sex workers, and 11% of trans people interviewed reported being offered PrEP at the facilities. Pointing to the reality that while PrEP is sitting in the facilities, the key population are not always made aware of and actually offered PrEP. So if you do not know about PrEP and not asked about it, so you are more likely not to get it, even if you are still negative from HIV. Key population are at the times refused access to contraceptives, specifically because they are a member of a key population group. As reported by 21% of people who are using drugs interviewed, 35% of sex workers, and 43% of trans people. South Africa faces a documented epidemic of gender-based violence, including homophobic, transphobic attacks. Sex workers also face extreme levels of violence and forced sex at the hands of clients, partners, and even police. It is critical that the key populations who face sexual violence feel safe enough to access the necessary services at the clinic, such as HIV testing and PrEP and STI treatment, emergency contraceptives, J88 forms, rape kits, counseling, and referral to domestic violence shelters. However, only 24% of GBMSMs, 39% of sex workers, 22% of people who are using of trans, and 22, people though thought staff were well trained to care for those who have experienced violence. Almost a third of key populations who we spoke to were unable to access STI services at the facilities. Too often, we hear reports of key population being discriminated against, or staff being in a hostile manner to those trying to access these services. A widespread access to harm reduction services remain outside the reach for most of the people who they are meant to serve. Those who have tried to access harm reduction services are often left without services or any information on where they could get these services. Only 5% of people who are using drugs were offered information of where they could get new needles. Only 7% given information on where they could get methadone. And only 2% were able to access drug dependence support. Services accessibility must be improved to ensure that people who are using drugs are met on additional barriers are created to being able to take drugs safely or be supported to stop. The availability of gender-affirming services for those who need them is critically important, yet only 33% of trans people say that the facility staff are respectful of their gender identity. 74% said that the healthcare providers use their names wrongly, and 52% said that they give them wrong pronouns. Trans people who do not live near these cities must travel long distances to get their services. This keeps it out of reach of those without access to transport monies and places to stay. It is possible that PEFA and the department have committed to establish one center of excellence per district. However, one site is just not enough in districts that are vast. And these sites will not be providing a full package of services or hiring new staff that is sensitized to the needs of the key populations. We urge the department and PEPFAR that at least establish 2 sites per population group per district, where a minimum package of KP-specific services are made available, and where facilities are highly sensitized to the needs of the KPs and to provide friendly, safe, and confidential services to the KPs. We will now move to the recorded stories.
Yes, I used substance, crystal meth. Then we go to our clinics. We don't have kind of things that we call counseling. As much as we had a youth center. Go to the youth center now. It's vanished. most of them who uses a substance, they taking needles. You get my point, Molong. It's obvious. It's blood to blood. I don't know your status. You don't know my status. Most section e ke le mo yone clinic ya rona ke Tsholofelo clinic. E ke tseba nna ko reng. Some of those people who work in there, they giving these people kind of syringes because where am I going to get a syringe whereas I'm not working at the hospital or at the clinic? Some of them are busy selling ARVs. You get my point? Just look around.
When we go for HIV testing or the STI testing, they'll be asking us questions like, Bo, when last did you have sex? Are you having multiple partners? Okay, those questions are sharp. And Bo, they'll be forcing us to bring our partners. What if I'm sleeping with somebody who doesn't want to be known? And then they are forcing me to bring my partner. Or sometimes they'll be if I come today, I go there today. Maybe I went last week, I tested last week somewhere else. Then I go there to the clinic today. They asked me to test, and I said, okay, no, I'm fine. I tested last week. They forced me to test, even if I don't want to. They say, if you don't test, we are not going to help you because you have to test before we help you. What if I don't want to test today because I tested yesterday or days before? So if I don't want to test, can I not be forced to test? This issue of misgendering us, it's offensive. It's offensive to me. It's very offensive. I hate it when somebody misgenders me. How can you see a person who is a woman, like physically you see a woman, but you call them a he? Yes, I won't argue. My ID book it's male, but I don't identify as male. I take it people who are in health, they should be trained on how to deal with patients, how to respond to patients. If I get there, if she sees or he sees something that's he misunderstands, he should ask before misgendering. He should ask me, because now I see a woman and here it's written a male, how should I address you? But then they don't do that. They would rather see, okay, the ID says male, Mr. is this and that, is this and that. You see, it's quite offensive. So I believe the health people should go, like the department should make sure that there's a training or some kind of a workshop where they are taught on how to talk to us, maybe how to address us. They should ask us, okay, address as a male or a female because I see two different things here. That would be fine with me. That would be fine, honestly.
To those who are HIV positive, they will be ousted to the general public in forms of humiliation by exposing their HIV status. One, not even now, the patient is now discouraged to go in for their treatments because of what the nurses will be saying to them prior to getting that treatment. Now that leads to the statistics spiking are amongst our youth, the LGBTQIA plus community. That also breeds the stigma that we are facing. Even as this interview is going to be publicized, we are going to be stigmatized. We are related onto the negative aspects of being LGBT in South Africa or in the whole world generally. We are being inflicted with such pain, and sometimes it's really tiring. But now, we cannot give up. You know what? Now I will appreciate, not to how do I want it to run? But I will appreciate if government take their nurses to workshops, educate them more. Maybe they are there, they are based on their work, that we have to treat a patient like this. But after all, they have to know they are sex workers, they are homosexuals, they are etc. You understand? They have to know how to treat each and every one of them and know the privacy. You understand? Because there is, in all of these clinics in Mafikeng that I have went to, there is no privacy. You can't go to consult and then it's one-on-one with you and the nurse, nothing like that. It's either she's gonna be with a friend there chatting or attending the phone or going up and down, opening, like you are not free. You understand? Sometimes they pause you. They ask you, what is the problem? After they say, no, wait for a minute. They attend their phone. When they're done, what were you saying? You understand? Let the government take their time to remind the health workers of what they are here for. Maybe I bet the patients, the motivation is not there. Yeah.
Okay, hi guys, my name is Tia Minso, very well known as Cutie. I identify myself as a transgender woman, and I use the clinic here, Motlhabeng Clinic, because it's the nearest one, and also Bopilong Hospital. The service there, honestly, it depends on who's helping you, because people are different and they're treating us differently. When I go there, and I find someone who would help a person genuinely, no matter the race, the gender, and whatsoever. They would just help me, even if they find out that I'm a transgender woman. They wouldn't question or say anything that's offensive or ask a question. They'll just help me and stay out of my businesses. But then if there are these people who are judgmental, they would call their colleagues to come and witness what they are seeing now, question us, ask a lot of questions that we're uncomfortable answering. You see, with regards to us, the confidentiality, I think it's just like the one I've just talked about. It depends on who is helping you. Other nurses are committed to their work and they respect their oath that a doctor-patient's confidentiality it's that and it stays that way. Others, they would not keep up to it. So it's just like that. With regards to, I once went to Motlhabeng Clinic to inquire about a primary. Last year I was on primary. I was taking primary as a transgender woman. So I was taking a primary. I went there to inquire about it. When I went there to inquire, the nurse who was helping me said to me, these pills are not for you. They're not for you. They are for a certain old ladies, blah, blah, blah. She said a lot of things that were offensive and I was pissed. So she called other nurses. Come and listen to this one. She's saying this. He was saying this, he's saying this, he's saying that. Okay, I sat down, I explained because I wanted to get help. Because I rely on them, I need them. I sat down, I explained my story, but at the end of the day, I did not get help because they said they can't help me. They don't know anything of such, so they can't help me.
I would like the health department to help us with planned patient transport. That's the solution for now. Because we tried asking for hormonal replacement therapy, treatments or the pills or the injections that we need from the facilities, and they refused to give us because our lifestyle is too complex to can understand whether this is true or not. Yes, there are some mental steps that we need to take. It's a holistical approach, not only just pills and potions and injections, but now we need to be assessed. We need psychological help as well. We need other things that can complete this whole transitioning as a whole. So if they have claimed that they cannot help us, can't they at least, if there is a planned patient transport that can be issued out for us and referral letters to the big hospitals that are actually rendering such services, then we are able to can go without having to worry about transport. That is now the solution that we can have, because failure to doing so, there are so many other issues arising from not only just going to the healthcare facilities and accessing the services, even general services. We can't even go due to the maltreatment that we receive from the healthcare staff and doctors who are not understanding, who choose religion over their jobs, simply because now they can't help us because it goes against the religion. Now, if they were able to can now provide us with a transport that will take us to the facilities that are going to help us, then it would be better. Now, there are so many, it's not only just in Mafikeng, it's in every district that we are having the same challenge and we are not getting help. That leads to us being accused of self-medicating and now going into the black market to access the pills, which is dangerous because we need the doctors who can monitor as we are taking this treatment, who can monitor our bloods, who can monitor the levels inside the body, etc. We don't have access to that.
Ke dula mo Kanana. Ke bile le dilemo tse 7 ke ntse ke kula, ke na le HIV. Hoduma HIV ka hla mathopa ana ka ha so fole le fandag. Kliniki e ke tsamayang ke ya Majara, Sephapu clinic. So ke batho ba nhlokometseng, ba ntreatang sharpo, ba nhlapisa le mo maqebeng e ke nang le one. Treatment ya bona ke e thabetse, le dipidisi ba ntlisetsa tsona mo botlong because ha ke kgone ho dula ditulo. One thing e leng ha ke a rata ka 2016 ha ke qala ho kula, ebile taba ya hore sepetlele ko ne ke ile teng ha ke a thabela treatment ya teng. Bang admitile ka robala sepetlele, bang kuka bang kisa ko theater. So ho tsweng ha ka mole ha ke discharge, ha ona next ke fumaneng treatment ya mo, ke discharge fela ka dipidisi tsa di-pain. So ya ba ke tla mo tlung, ho tlo fitla mo tlung ha ona next e ke sebedisang. Batswadi ba ka ba re ke sebedise metsi ya letswai, ntse ke a sebedisa metsi ya letswai ho fitlela le nou ha ke so fole. So sepetlele se ntse se ke kadileng ke kulela ho sona ha ke admitwa ko sona ke Tshepong Hospital ko Klerksdorp ko Jobeting. Surgery e ba nkentseng yona e yang affectile haholo because mathopa anana the way ke utlwang batho ba bangata ba bua ka ona ke mathopa tlamehile kgale a fodile. Ya yone e inkutlisa le bohloko teng moo. Ke motho ke na le maikutlo. So dilemo tse ke di dutseng ha ke sa ratana ene ke gay, ha ke sa kgona ho tsamaya le bana ba bang.
The treatment from health towards the LGBTIQ plus community, it's not good because when we get there, they make jokes out of us. They'll be laughing at us, they'll be questioning us, they'll be saying offensive things. So I feel like health should do something. I don't know what, because now the only thing I'm thinking of it's the training or the workshop that okay, this is how you should treat, like we should be treated like anyone else. When a woman gets a clinic, when they take out their IDs, ba register-a, ha go gote mosadi ke o tle clinicing and what o tlo go thusiwa fine because they see ba bona gore okay, it's a lady and on the ID it's written lady, they won't say anything. But when I go, it's a different thing. Ke tla begin ID, it's written male, and then o tla ba bitsa who's next to them gore okay, come and see you, now what do I do? Or without doing that, Mr. This and that. I prefer to be asked, how should I address you? Yes. So I don't know. Health should do something. Department of Health should do something with this issue because, but other community, the community members are LGBTIQ plus community, they'll end up not going to clinics because ba discriminatiwa ke manese. Imagine you discriminate a professional nurse. How are we supposed to get health services?
Hello, my name is Kiabetu Makotla. I was born and bred in Mafikeng. My pronouns are she, her, and I'm a trans woman. Yeah. The challenges that I face at a healthcare facility, especially in regards to getting my hormonal replacement therapy treatment, is that there is lack of understanding from their staff. One, even the doctors themselves. Some of the doctors are ignorant in terms of helping us or giving us the services that we need as trans women. I'm also challenged by the general treatment of the staff and their fellow patients, especially now when you get ousted by your ID. So it's not only just the medical side of things, it's a holistical issue that we are facing as trans women in South Africa. Having access to rights or having access to services that will give us the identity that we deserve or that we choose to identify ourselves as. So we are being ignored in receiving such services. We are being ignored based on who we are genetically, not by how we present ourselves, because there are two differentiations between gender identity and sexuality and etc. Yeah.
Okay, my name is Ritshidze Ramzamai. I am born and bred in Kutsong, Carltonville, Westland. So I am a transgender woman. I started transitioning by the age of 18, 2019. Being at the region where, like Johannesburg, hormone replacement therapy is not a problem. So since I moved from Johannesburg to the Northwest, due to studies, I struggle to access hormone replacement therapy because I have to travel now and then to Johannesburg from Mafikeng. So it's costly, and sometimes I stay without HRT, and that affects my well-being. But they can organize people from the LGBTI, and then the clinics provide the primary services for transgender people, like psychology and therapy, and then access to hormone replacement therapy, because a lot of transgender women here in Northwest Province, they are not on HRT and they self-medicate and end up having their health at risk. So I would like the Northwest Province to provide at least those primary services for transgender women.
When we go for HIV testing or the STI testing, they'll be asking us questions like, when last did you have sex?
It's the same faces, but on different issues. It's the same person experiencing a lot of different issues for the mere fact of being a KP in our country and the inability to access healthcare services in our public healthcare facilities. We are going to have community stories just before the recommendations from the chairperson.
Dumela.
Greetings.
Ke nna Tshidiso Mothopi from Kanana Okni. Ke nna Tshidiso Mothopi from Kanana Okni ne?
My name is Tidiso from Kanana Okni.
Okay. Ke nka treatment ya HIV ko Kanana Clinic ne?
I take my HIV treatment from Kanana Clinic.
The only problem I ke experiencing ko that is like ke nka like nka fita like ko early ne? But then ke go tswa ka bo 2 or 3. Where else but after na but to suba.
The problem that I've experienced is that I go to the facility early in the morning and then I will go back home around 2 o'clock. Whilst people who came after me, they're being helped before me while I was there first.
Because maybe just because ke gay, that's why I'm treating.
So my thought is that just because I'm a KP, that's why they're treating me like this.
And the other thing happened, like, go to consultation room, ne? And I understand if nurse into sane, what about a nurse anyway? Then
They have this tendency of, instead of helping you at the consultation room, the other nurse will come in, they will chat, and then they will go out, continue chatting, and forget all about you.
Then I started from scratch. Kana really guy, where else? I live because you took us when I thought.
And then when the nurse comes back inside the consultation room, she will ask me from the start to say where we were, what was I saying, and what was my problem.
That's the only problem. But then, other than saying on a pasha,
other than that, I'm okay.
Dumela.
Greetings.
Ke Letlhogonolo from Leeudoringstad in Northwest.
My name is Letlhogonolo from Leeudoringstad in Northwest.
Nna ha se ke kopane le mathata ko tleliniking e ke dirisang ya ko Leeudoringstad ko toropong.
I have not experienced any problem while I was attending the clinic in Leeudoringstad.
Treatment ya bone mo go nna e le sharp, ha se ke feel any homophobic vibes or attitude because of my sexuality.
The way that they're treating me correctly, and I have not experienced any vibes from them.
Problem e ke nang le one fela ke gore ha ba ruti batho ka di PrEP. Ha o le ko tleliniking, you will never hear gore ba bua ka di PrEP or ba go advise gore go na le dilo tse di bitswang di PrEP, dilo tse re di bona fela mo di internet or ha re dutse as difference re bua ka tsone.
The only problem that I have with the facility is that they never give us information about PrEP, how is it taken, or they do not even offer us the PrEP.
And ke ne kopa gore e ka re ko Leeudoringstad go ka nna le di workshop or eng go rutiwe batho ba ko ditleliniking ka go gona le batho ba bitswang bo di-gay, go na le di-trans, because different tse dingwe tsa rona da complain gore ga be le ko tleliniking ha ba kry behavior e sharpo, ha ba itse gore ba identify jaka eng ba dira joke ka bona.
My plea is that they should, the Leeudoringstad facility should have, the workers should have the trainings regarding the KP, how to treat them, how to address them while they're at the facility.
Yeah, thank you.
Thank you.
Dumela.
Greetings.
Nna ke nna Itumeleng Diete ke tla ko Khuma ko Stilfontein.
My name is Itumelang. I'm from Kuma in Stilfontein.
Ke tsene ko Khuma Clinic. I get tested ko Oramo ka 2011. Be ke tsena ko Khuma Clinic ka 2011. Ilo ke krile referral from Oral to Khuma Clinic. There's a point where tshwantse ke nke di treatment ya ka ya HIV ko teng. So go tseneng ga ka ko the reason ke ne ke le ko Oramo is because of ke ne ke tshaba ko Khuma, because ke itsagale ko Khuma o ke yone, so ke tshaba stigma le discrimination. But then ke ne ke sena choice ka ke boela ko Khuma Clinic. Ha ke fitla ke be ke thusiwa ke this other lady o tlhokafetse no ke manaise. Ke counselor ko teng, so re dirile counseling rotlhe ka tswa sekolong go rotlhe. Abampulela file, and then ka kopana le Sister Mita. She's very gay friendly. Go Khuma Clinic.
Okay, I attended Oram Institute instead of Kuma Clinic because I was afraid that I was known around that area. And then I was transferred back to Kuma Clinic where I met Sister Mita, who is friendly towards the KPs.
Yeah, so Osmita arang initiate, and then from there ke tsela treatment ka go Khuma Clinic. Otherwise Khuma Clinic I kena mathata lone. Na nke ke fola go Khuma Clinic go bua nnete. Anke ke fola line.
Okay, I met Sister Mita. Sister Mita helped me with everything and she was friendly. And then that's where I take my medication, and apparently I do not queue.
I don't. So anke ke fola go clinic. The moment ke tsena ka gate, gona le this male name ke Ntate Deni. It's like ke tla go Ntate Deni or ke tla go Smith. And then the patient there itse ke tlo feta ke dumedisa, dumelang. Be ke fetela nna ke ke go consulting room.
So every time when I attend the facility, I do not queue at all, and everybody at the clinics know that I do not queue.
But then for nna ba ntshwara sharp ge, because ke motho itsagaleng, ke phela ke bereka ka batho, ke mo industry ya catering and deco, so Mariano for batho ba bang, the other LGBTI community, the treatment is not the same.
For me, while I'm at the clinic, I'm being treated well, and I'm well known around the community because I'm doing work with the community. But as for other KPs, they are not being treated well.
Like last month, I had a friend abaya go Khuma Clinic alo test for HIV.
Last month, I had a friend at Kuma Clinic who went to test for HIV.
Yeah, nkare di counselors tsa rona di ka fiwa training gape.
I would suggest that our counselors should be trained again.
Ba rata shortcut.
They like shortcut.
Ha o tsena o tlo botsiwa go itse HIV eng? Ke HIV. Ke virus e tsena mo boding ka sex. Ba go beela mo. Ha ba fetsa ba go testa. Distrip di ka di pedi means O positive. Okay, wa itse ke re tshwantse o take di ARV. Batho ba modimo. Wa ntlhaloganya se counseling so seo.
My plea is that the counselors should be trained again and again, because now when you are at the consultation room, they would ask you, or you would ask them what is HIV, they would say HIV. And then they will tell you how do you get HIV, and then if you see 2 straps on the test, they would tell you that you're HIV positive and you should take your medication, and that is it.
So Chumieka after that abang phone on WhatsApp ile ka tshwana go mo kgatlhanyetsa. O tle antse a lla go tswa go clinicing. I can imagine batho ba morning a tsena mo roomong ya testing a ba tswa a lla, and then tshwantse ke mo kgatlhanyetse, and then I had to do the counseling after that.
I had to do the counseling for my friend because at the facility they did not do a proper job. And my friend came out of the consultation room crying, and I can imagine what was everybody thinking at the facility by then.
Marino ya no siame, o siame re buile, she's okay. O tlo simula treatment ga ge no, o tlo a dira ko clinicing.
So I did counsel my friend, she's okay now, she's about to start her treatment.
Thank you.
Dumelang.
Greetings.
Ke nna Tisetso ke eme.
My name is Tisetso.
Ke tswa ko Klerksdorp, Alabama.
I'm from Klerksdorp, Alabama.
Ke nnile le bothata le sister wa ko Alabama clinic.
I had a problem with the sister from Alabama clinic.
Ke gopola sentle last month ne.
I remember correctly last month.
I'm on PrEP. So ke ne ke ya go tsa dipilisi tsa ka tsa PrEP.
So I went to fetch my PrEP medication.
Ke a fola line.
I queued.
Ke a tsena. Sister ke a tsena ke a dula mo fatshe. Are e ya gogo.
When I entered the room and sat down, the sister said, "Yes, Gogo."
Ke be ke didimala. Ene ko Alabama clinic go gopole go na le sister wa nurse ke lene ke traditional doctor.
And at the same time, at the Alabama clinic, there's a nurse who is also a traditional healer.
Ke a dula mo fatshe, o so ke mona file.
I sat down and I gave her my file.
O ntha are le tla go tsaka ka dipilisi mo ke ngo sa tse ditlhare o dinwe.
And then she said, "We came here to fetch the medication. Why can't we take the traditional herbs?"
Traditional medicine. Sheba, wa itse ka go kwata hela. Ke a ke ema ke re osi. Nyena ha letla go go rona le batla thusho. Ga re le re wa ile sa go di medical tsa nyena.
So by then I stood up and I stood up and told the nurse that whenever they come to us and ask for help, we do not ask them why can't they go to the doctors and use their medical aids.
And ke ke mora ke sister, e re ke go rute because nka re ha wa rutega.
And I told her that, "Sister, listen here, let me teach you."
Ke go bolelela traditional medicine go ya ka tsela ya teng. High cure a disease, a chronic disease or any disease e tseneletseng. Ya e suppressa nyana hela.
And I told her that the traditional medication does not cure a disease, but it suppresses it.
It's very important gore ha ona le that disease e ya ko health ko di clinicing o go tsa treatment ya gago. Ha re ntshe disease mo go ope, we just re okobatsa.
It's very important that when you are HIV positive, you go to a facility or clinic to collect your medication instead of taking a traditional herb and saying that you'll be healed.
So ke batla go itse gore rona traditional healers immediately ha re tsena ka di clinic yana right re tla be re ipotsa gore modimo e ka re hala ke tsena tla bo go di modimo ke nga sa go nwa ditlhare tsa gage o tla go tsa dipilisi tsa rona.
Every time when I enter the facility, I would wonder if they would say to me, "Why can't I take my traditional herbs instead of taking the pills from the facility?"
So ke ne ke kopela gore le rona as traditional healers ha re tsena mo le re tlhompeng hela ka re le tlhompa go dindombeng tsa rona. Thank you.
My plea is that my plea is that the nurses should respect us when we're at the clinic as we are respecting them while they enter our rendezvous or consultation rooms. Greetings.
I go by the name of Kahontle. The name of Kahontle.
Oh, my name is Kahontle.
I am from Taung. So, kiskile ga ku clinic ko Gateway Clinic ya ko Taung.
I went to Gateway Clinic.
Ha ke fitla ke ne ke sitse ke nna le bothata mo setlheng mo.
Oh, I had a problem in my bladder.
So, ke fola line in little ke fola ke na patient ke fola line.
The queue was long and I had patience.
So, ha ke fitla ko room ke fitla nurse.
When I arrived at the consultation room, I found a nurse.
Ka mo bolella bothata wa ka gore ke na le bothata 1 2 3 go etsagala so ka setlha sa ka.
And then I told the nurse what was going on.
Question antla e ileng a mpotsa yone ke gore, "Are you a boy or a girl?"
The first question she asked me was that, "Am I a boy or am I a girl?"
Ka mo araba ke re ke mosetsana.
I answered her and told her that I'm a girl.
A re mo gona kante wa pere ka bashimane.
And then she asked me, "Why am I dressed as boys?"
Ka mmolella ke re ke mmele wa ka ke apara the way ke batlang ka teng.
And
My
I
body, my rules.
I told her that my body, my rules.
So are because it seems like o batla go itira mosimane. Why can't o sa itse why o sa itse serera pedi ewa?
And then she said, because I wanted to be a man, why can't I take that pain as a man? And I told her that I never said I was a man.
My gender doesn't represent my sexuality first. My gender doesn't represent my sexuality. It seems like urudi and na hagitlo assist someone urudi.
The nurse said, it seems like I'm rude and she was not going to help me.
So kare mo gane na o tlo go nthusa like it or not.
I told the nurse that she was going to help me, like it or not. She went out of the consultation room, leaving me alone. I stayed inside the consultation room.
Next patient, next.
And then she came back, found me in the consultation room, and then called another patient while I was inside the consultation room.
So Kadi said, okay, let me leave.
I decided to leave. And I told my parent how they treated me back at the clinic and they did not help me.
I decided, okay,
She decided that we will go to the facility the following day. We went back to the facility the following day and we were assisted by a male nurse.
But they were a male nurse, part of LGBTQI.
The way that I saw things, that a male nurse was part of the KPs.
So yeah, yesterday ke ne ke le mo go etsagetse 1 2 3 le ene amfa feedback ya gore yes the nurses the colleagues tsa gage di yalo di treata batho otherwise.
I told that male nurse what has transpired the previous day, and then he told me that all the nurses in that facility treat the KPs like that.
So yeah, at least abang assist ka khona go boela gae. Thank you.
And then that male nurse assisted me. Thank you. Greetings.
Alabama.
My name is Ofense from Clarkston, Alabama.
I tested positive 2021. Ele gore ke ne kapa a friend of mine go go clinicing, so one of the nurses abankemisa a re ha batle go test. I was like, okay, peria.
So I tested positive in 2021. I went with my friend at the facility, and then the nurse stopped me and asked me if I did not want to test for HIV.
So I went with her, and then she consulted with me. If o ka kya gore o testa positive wa go dira eng, then cause ke na ke niplela gore ke sharp, there's nothing wrong, I can HIV.
She asked me if I tested positive, what was I to do? So I, for one, did not expect that I will be HIV positive because I thought I was okay.
Then we took the test. You tested positive. I was like, okay.
She took the test, and then after a while, she closed her eyes and said, "Oh, Fenze," and then she told her that she tested HIV positive.
Yeah, so she counseled me and explained everything, and then she gave me the medication, and I went home. So I was taking my medication properly, then they gave me a date. I went on that date. I went to a different nurse. She was rude. When I go, she left the door open. So can you please close the door? a ba re no gwa tšhesa. So ke be sheba ko morago because the door is open, the people ba ba fotseng line like they're right behind me. So ke re he bathong ba tshega ba re o go dira eng tšhong, ke re o gane go kwala monyako mme o. So then mme o she can I just finish this part? A re le tletse mo tleliniking go tla go kwala le tlile mo tleliniking go tla go kwala monyako ya mo tleliniking mara le itse go bulela bannete gope. I was like, ever since that day, I the second date. I never went back to that clinic, Alabama clinic. I never went back since this year, January, till now. I see ke go clinicing because to think gore ke go clinicing engwe, ke tlo ya ka mentality ya gore what happened at the previous clinic is going to happen gape go clinicing engwe.
So what had happened was, on my second visit, after being initiated on ARVs, I went to the clinic and was assisted by a different nurse who was this time rude. And upon getting into the consultation room, I requested that the door be closed behind me because the queue of people that were in the facility was right behind me, very close to where I was being consulted from. The nurse declined closing the door, saying that it was hot. And the patients laughed, asking what was actually happening between myself and the nurse. I explained to the patients on the queue that the nurse was declining closing the door to consult me privately. And they laughed. As they were laughing, the nurse continued to say, "You want to come to the clinic and close the doors, but you can open your legs for men." Which was my last visit to the clinic. I never went back to the clinic. I have not been taking my ARV since then, which was in January, and I have a fear of going to other facilities because I fear that I'll be treated the same way. Thank you.
Thank you.
Dumelang.
Greetings.
Ke nna Lebogang from Orkney ko toropong. Ke nna Lebogang from Orkney.
My name is Lebogang from Orkney.
Last year ke ne use Grace Mogomo clinic.
Last year I was using Grace Mogomo Clinic.
And then I had a issue ya gore consulting room le diabetes testing do together by the components.
Oh, the problem that I have is that the consultation room and the counseling room, it's in the same room. They are sharing the room to do their work.
And then I take my test, and then the counselor about mixed the file the patient omong.
I was tested and the nurse mixed the files.
And then akwala the results ka mo filing ya patient engwe.
The nurse wrote my results on another patient's file.
And then my concern it was if ever I was negative, go no tlo go diragalang.
My concern was if I was negative, what was going to happen?
Because already that patient obone the results
Because already that patient saw my result.
So, but now since I've complained, then ba kgonne go e share. Since you complain ka the counseling room le diabetes room, ba kgonne go di separate.
Since I've complained about the counselors and the nurses sharing the room, they have managed to separate the room.
And then the issue engwe ke go ya go Chris Mogomo, emergency room ya teng e nyane.
Another problem at Grace Mogomo is that the emergency room is very small.
And then gona le di room tse ding tse available tse ba sa using.
And there are other available rooms that are not being used.
So the concern is, if ever, go tlo nna le motho o kulang serious, and then go nna le patient engwe emergency room, batho ba kenya kaofela ka phone.
So my question is, if there are two patients that are critically ill, are they going to put them in that small room together?
And then, arena access go kry di loop, di condom.
And then we cannot access the lubricants and the condoms.
And then we know gore di teng, but aba di display mo go di bonang teng.
We know that the lubricants and the condoms are available at the clinic, but they do not put them at the display where we can access them.
And then our counselors, ke nagana ba tlhoka training ya PrEP.
And one other thing, I think our counselors need training of PrEP.
Because aba ruti batho ka PrEP, banka di test fela, and then from there, wena wa iponela o tswa yang.
They test you and then you will see what you do after that. They need to be trained again on PrEP and how it works.
And as gay people, my concern is ba upcoming key populations and then about
One other concern that I have is that they should be trained, because I work with KPs and there are other kids that are growing up who are becoming KPs, so that is my concern. Tomorrow they will not be able to take care of themselves. What is it that is going to happen to them?
And then I would like Ritshidze gore the program on the clinics, because we need them.
And my request is that Ritshidze for Ritshidze to make programs at the facilities to teach people about KPs.
Because rona nna ka for ha ke chasitse someone o tla bang WhatsApp o na le bothata kae kae ko tleliniking ha ke di tsene ke re ka for ka chase, and then someone wa key population o tla ba ang WhatsApp amplela o na le bo problem ya kae wa itlhoga, and then maybe it tla ba ke e batla ke attend, so ke chase I want to get
At 4 p.m. I knock off, and then I would get a text from other KPs to tell them that to tell you that they are at the facility, they need your help, and when you by then you'll be home.
Yes, thank you.
Thokoza, yo.
Thokoza go.
Tumela agwe Pinky from Klexdop Jobetina.
My name is Finky from Klexdop Jobetina.
Ke tsama clinic ko Jobetin Clinic.
I attend clinic at Jobetin Clinic.
Ya khale.
Old clinic.
So ko clinicing ya ka ba ntshwara hantle. Ke a tsena fela ke tswa cause ba tseba I'm a traditional healer. Ke na le bakudi ba ba mpagetseng, so ke fole ke tsa fela medication we ke tsama.
I never struggle when I go to collect my medication at the clinic, because they know that I'm a traditional healer. I have sick people to help, so I do not queue at all.
So problem ya ka ko clinicing ke hore ha bana di loop. So ha ke batla di loop ke di latela ko tshepong ko gateway.
My problem is that they do not have the loops at the clinic, so I have to travel to another facility to access the lubricants.
Re bona di condom fela, so ne re kopa thuso hore re ka kreya di loop ko Jobetin Clinic.
My plea is that can Jobetin Clinic have lubricants for the KP people?
Thank you.
Dumelang.
Greetings.
Nna ke tswa ko Kanana.
I'm from Kanana.
Ke ne ke tsamaya clinic ko Kanana Clinic.
I used to attend clinic at Kanana Clinic.
Ho na le letsatsi leo le ngwa etsala wa ke ye ko Klexdop ne ke theoela, then be ke kena mo mobile clinic.
There was a time whereby I was working and then I decided to attend the clinic in town.
Mobile clinic.
Mobile clinic.
Ka fumana HIV positive, and then ka be ke khutla tlare hona mo ke ya clinicing ya Kanana Clinic.
I went there to test. I found out that I was HIV positive, so I went back to Kanana Clinic.
A ke fitla Kanana Clinic ka fa receptionist pampiri na ba mfile yona ko mobile clinic.
When I arrived at the facility, I gave the receptionist the paper that they gave me at the mobile clinic.
Letsatsi leo le la dikela, then the following day hape ka tlameha hore ke kgutlele clinicing ka pampiri because ne ke sa fumana thuso ka nako eo.
That same day, they did not help me. I had to go back to the facility the following day.
Le teng ba se nthusi ka fetela ko Grace Mogom because receptionist a teng o na le moody too much.
They did not help me because the receptionist was too moody, so I went to Grace Mogom.
Grace Mogom ke ile ka thuswa ke also mong a sebetsang ko Oram.
At Grace Mohomo, I was helped by another lady who works for Aurum.
So ndo ke kopang hore change go Grace Mokgo ko Kanana Clinic because go tloa go Grace Mogomo ya go di dulang teng ke tlameha ke spend ho ya teng. At least the receptionist ka change attitude ya hae.
So my plea is that the receptionist change the attitude, because from where I stay to Grace Mohomo, it's a long distance and I spend the money that I don't have. So my plea is that the receptionist at Kanana Clinic should change her attitude.
Thank you.
Thank you.
Okay, thank you very much for the stories. I know they were very long. It's because of the challenges that KPs often faces. However, I would like to also again commend those friendly healthcare workers towards KPs and make sure that they are accessing services with a smile. I was taken aback with one of the KP that it's a KP person, and he was able to assist the KP. So that shows that one of the recommendations that at least in each KP facility, there needs to be a KP so that we can be able to sensitize nurses and all those need to get services can get services with smile. However, as much as some of the stories seem to be funny and we're laughing with it, but are dehumanizing and are really serious, and I think they should be taken into consideration. I know that the first story that was showed in the screen, we are working with the Department of Health, especially the Office of the MEC, to assist the patient with the help of Mayor Judy Malibane in particular. However, I think officials here have listened to other stories which they will follow up, and I would like also us to follow up of a story of the gentleman, of a person, not a gentleman, of a person who was denied access, and because of the way the nurse treated the person ended up not going to the facility. I think we need to follow up with that, working with Ritshidze, because they can connect you with the person. But also, you know, I hear most of the participants are saying Ritshidze must try to have programs and all those things. Ritshidze, unfortunately, doesn't have that much progress or a budget to do all what we can be able to do or what we would like to do. But working together with the Department of Health, we believe that we can manage to address all these challenges and have programs that communities needs from both Ritshidze and the Department of Health. So I will go straight to the recommendations. The first recommendation is the Department of Health should ensure that all clinic and non-clinical staff, including security guards across public health facilities, are sensitized on the provision of KP-friendly services to ensure a welcoming and safe environment for all KPs at all times. KPs must be involved in the implementation of these training modules. I think this is the recommendation that just I said a minute ago. Any reports of poor staff attitude, privacy violation, verbal and or physical abuse, harassment, or service being restricted or refused should be urgently investigated. So I think we had so many of those, and I would like the Ritshidze team to work with the department so that you can continue to investigate those issues. The Department of Health and PEPFAR should expand the Center of Excellence model to ensure that at least 2 public health facilities per population per district serve as key population designated service delivery centers. A minimum package of services should be made available at these facilities as outlined in the State of Health report. Easy referral and adequate resources, including transport money for transport or money for transport, must be provided for people to take up these services. PEPFAR must support these facilities with additional staff and resources to provide comprehensive health services to the specific key population being served. Ensure that HIV prevention tools, including lubricant, external and internal condoms, PrEPs, and PEP, are made easily available at all public health facilities. Make available external and internal condoms as well as lubricant in a range of spaces across the facility, i.e. waiting areas, toilet gates, pharmacy, consulting rooms, quiet areas outside, so people can freely and easily collect them. Ensure PrEP is offered to everyone, including key population who are not living with HIV or who test negative for HIV, with information shared on its benefits. Ensure no staff member ever tell the key population to use Vaseline or other oil-based lubricants instead of water or silicone-based lubricants. Now we are moving to index testing, which will be led by Mary.
Ngiyabonga, Chairperson. The next set of issues is going to focus on index testing. 89% of facilities monitored by Ritshidze engage in index testing, and of 527 people living with HIV interviewed, 44% said a healthcare worker had asked them for the names and contact information of their partners to test them for HIV. While index testing has the ability to help identify individuals who may have been exposed to HIV earlier, it must be implemented in ways that do not cause harm to individuals or undermine their rights to consent, privacy, safety, and confidentiality. Yet in terms of consent, only 72% reported that they were allowed to refuse to give the names of their partners. Nearly a quarter of sites had 0% of respondents saying they could refuse, including Bapong CHC, Litlabile CHC, Grace Mohomo CHC, and Tulufelo Clinic. Index testing must always be completely voluntary. This is possible as seen at the 8 facilities where 100% of people reported that they were told that they could refuse participating in index testing. Only 81% of facilities say they screen for intimate partner violence as part of their index testing protocol. Of 527 people, 73% reported that they were asked about the risk of violence from their partners. This is a concern and a violation of people's safety and privacy. 29% of facilities who do screen still contact all partners regardless of the outcome. There is no point to the intimate partner violence screen if contacts are just notified of their exposure anyway. 3 facilities had almost no one reporting being screened for intimate partner violence. There must always be an IPV screen to protect people's safety who undergo index testing. This is possible as seen at 9 facilities where 100% of people reported that they had an IPV screen done. Positively, the majority of sites said if a person living with HIV screened positive for IPV, they offer them services either on site, which is at 79% of the sites, and or by referral at 64% of the sites. All facilities should be able to provide on-site referral for IPV services. Screening for intimate partner violence without adequate IPV services to respond to individuals' positive screen is dangerous and is also unethical. Referrals must be actively tracked to ensure individuals access them, and referral sites have adequate capacity to provide the services required by each individual. We are going to move to the recommendations relating to index testing.
The recommendations are as follows. The Department of Health and ORAM should follow all protocols outlined in the National Department of Health guidelines on index testing, including that index testing is always voluntary. All healthcare providers ask if the individual partner have ever been violent, or record the answer to the question before contacting the sexual partners. No contacts who have ever been violent or are at the risk of being violent are ever being contacted. Adequate IPV services are available at facility or by referral. Referrals are actively tracked to ensure individuals access them, and the referral sites have adequate capacity to provide services to the individual. All adverse events are monitored through proactive adverse events, a monitoring system capable of identifying and providing service to individuals' harms by index testing. Comment boxes and other passive systems are necessary but inadequate. After contacting the contacts, healthcare providers must follow up with the individual after reasonable a period of 1 to 2 months to assess whether there were any adverse events, including but not limited to violence, disclosure of HIV status, dissolution of the relationship, loss of housing, loss of financial support, and refer them to IPV center or other support services if the answer is yes. Data on such occurrences must be shared. Carry out an investigation into all DOH and ORAM staff carrying out index testing to assess the implementation of index testing. The findings of these investigations should be shared transparent. Suspend index testing in poorly performing sites until it can be carried out safely with consent. So now we are going for infrastructure and cleanliness, which will be led by Comrade Ludik.
Thank you, Chairperson. The country's load shedding crisis negatively impacts the provision of health in our clinics and can often lead to people waiting much longer to collect medicines or consult with clinicians. In the Northwest, the most common challenges include delays in finding files when filing rooms are in darkness, data capturers not being able to capture information, creating a backlog and impacting follow-up with people who have missed appointments and recall systems, and medicines and vaccines getting spoiled without electricity. Generators at each facility could resolve these challenges, but only 38% of facilities have a generator that is working and has fuel. Only 50% of facilities monitored in the Northwest were observed to be in a good condition. Of the 50% in bad condition, the most common reason is that the buildings are in need of renovations and that there are broken or cracked roofs, walls, or floors. 89% of facilities reported needing more space, down from 92% last year, with waiting space, filing space, rooms for medical care, rooms for private HIV testing and counseling, and storage given as the most common things facilities needed extra space for, impacting negatively on congestion, TB infection control, maintaining organized filing systems, and confidentiality. On overall cleanliness, only 60% of public healthcare users reported that facilities were very clean or clean. 21% reported that facilities were very dirty or dirty. 78% of Ritshidze observations found that toilets were in bad condition with no toilet paper and no soap given as the most common reasons, as well as toilets that are dirty, blocked, or out of order, or with no lights.
Now we go for recorded stories.
Ka di 3 tsa May ne ke na le appointment ke na le molwetse mo tlong ke mo tsela dipilisi so ke tswile ke tsene ko tleliniking ka 10 ka nna mo queue ka go kwadisa ga fetsa go kwadisa ka go fola for chronic medication. After that ga ke tsena ko consulting room file ne se teng ba ntha ba re ke emele ko thoko pele ba sentse ba batla file ba ko di-fileng ba ntha ba re no file re itlisitse ka ko. That's when re lemoga gore the file is missing. Rona re dutse ga re itse gore what is the way forward. Re confused ya la re tle re itse gore re direng because di-file ga diyo and ga gone re tlhalosetsang gore what should we do. Ke tsene mo tlong ka 4 o'clock ke tswile mo gae ka 10 ke ya tleliniking ke tsene mo tlong ka 4 ke tšheletse molwetse mo tlong. Tleliniki ke tsamayang ke tleliniki ya unit 9 so if unit 9 e ka improve di-service tsa bone maybe ga ba re ba starta ka 8 ene 8 ba di-file go na le problem e tona tota ka filing ya tleliniki. Department e train batho ba ka filing ya bone. Department ya health e oketse ma-nurse kore nakong ha re le mo queuing yane telele kore go le sister o one kore le ene ra mo filela but le rona o tswile mo gae o sa ja phakela ene le wena mo chronic ha ya go ja re mmona phoso le ene ke motho a kere department e bankanya mathata yone but re ska ra blame bo sister hell department e bone gore e provide service yang so re ka itumela tota le ka re thusa le bue le department ya health e abuse bagolo ba re ba ko ntle pula ena go le diphefo re mo ntle ga ba kgatale kore ke re ga ba re utlwele botlhoko re kopa re ba re utlwele botlhoko.
Okay, now we are going for recommendations. The Department of Health should ensure that all public facilities have functional generator with sufficient fuel so that health services and administrative work can continue during load shedding. Ensure that all public healthcare users are consulted, tested and or cancelled in private rooms. Carry out an audit of all facilities to assess infrastructural challenges, after which the department should develop a plan in order to renovate buildings and ensure adequate space to provide efficient, private, and safe healthcare services. The department must publish the audit results. In the interim, provide temporary structures and ensure that more people living with HIV are being decanted out of the facility and receiving longer hours referrals to reduce the burden on overcrowding clinics. Ensure that all facilities are maintained to the highest standards of cleanliness, including through implementing regular cleaning rotas. Ensure clinics have resources to provide soap and toilet paper in all toilets. Now we are going to talk about tuberculosis, TB, which will be led by Comrade Mary.
Thank you, Chairperson. In South Africa, around 300,000 people develop tuberculosis every year, and about 56,000 people die to TB. Yet, TB infection control in our public health facilities remains inadequate. By following a simple checklist of good practice, including key measures that were successfully implemented during COVID-19, facilities can be safer for the public healthcare users and the staff. With a checklist in mind, Ritshidze has developed a scorecard and a traffic light system to rate clinics on how good their TB infection control is. Clinics that adhere to all the measures are given a green light. Those that are on the right track but still off target get a yellow light, and a red light is given to those that are way off the mark on ticking the checklist for the 6 measures. In April and May 2023, 0 facilities were awarded the green status for checking all 6 measures on the scorecard. Ritshidze scored 9 clinics yellow status. This translates to 50% of the facilities being monitored, following about half of the best practice measures for infection control. It leaves 9 facilities of 50% of facilities surveyed, failing altogether at meeting the 6 basic best practice requirements to stop the spread of TB. We will have recommendations from the chairperson.
Okay, thank you. The recommendations are the Department of Health should issue communication to all facilities stating that all windows must be kept open. TB infection control posters must be displayed in invisible places in the waiting area. Public healthcare users must be screened for TB symptoms upon our arrival. People coughing or with TB symptoms must be seen first to reduce the risk of transmission. People coughing or with TB symptoms must be provided with masks. People who are coughing must be separated from those who are not while waiting. Secondly, carry out a full audit of all public health facilities in the province to assess TB infection control based upon WHO guidelines, after which the department should develop a plan based upon the infrastructural, human resource or behavioral challenges found in order to improve TB infection control. The department must publish the audit results. Now we are at the end of our presentations, and I would like to thank everyone who's been sitting and listening attentively and participating in this conversation or launching of this report. So without wasting any time, I would like to start by calling our partner organizations who are part of Ritshidze. I will be very strict on time, comrades, because I know when I talk to comrades want to give them mic. They are like me, they talk forever. So because we are working together, I will be strictly giving each of you 2 minutes, because I know that we've been here for so long, and then so that we can hear everybody. Also, the Department of Health need to give us their responses and the partners that are here. So I will start with Comrade Isaac Tsane from NAPWA.
Greetings, everyone. My name is Isaac Tsame from NAPWA. NAPWA stands for National Association of People Living with HIV.
Is it possible for you to stand up, my leader?
Yeah, not a problem, leader. This is the Isaac that was talking, sitting down. It's very sad. It's very sad that we have to come back every year and listen to stories of people, the same stories that we had last year, of people being neglected in clinics, people not being treated well in clinics. It's a setback, to be quite honest. And I think we as organizations need to work together again, need to sit down and strategize with the Department of Health and Ritshidze as organizations to mitigate some of these problems, because some of these problems can be worked on if we work together. The challenge that I have is of the gentleman, of the person that side who said they ended their treatment in January. I mean, that's very discouraging. It's a setback, because HIV has comorbidity, the other diseases that can come into effect that will affect you, that will make you sick even more than you are. Because I'd recommend that you please go back to the clinic or go to another clinic. That's my plea to you. But with all the compliments that were given to the Department of Health, we are very thankful for that. We are very thankful to those nurses that are working well with the communities. Thank you very much. I think my 2 minutes is up. Thanks.
Thank you, Tate Isaac. So I will ask Comrade Hope Raikane from Positive Action Campaign.
Amanda.
Awethu.
Amanda.
Awethu.
Viva key population, viva.
Viva.
Long live people living with HIV, long live.
Long live.
Pansi ka discrimination, Pansi.
Pansi.
My name is Hope Raikane from Positive Action Campaign. Today I want to shed light on a crucial issue that intertwines access to prevention equipment with the fundamental right to health. As we know, shortage in prevention equipment can have severe consequences, particularly regarding HIV infections. Such scarcity poses a significant challenge to achieving the global NSP 1990 goals, especially amongst key populations, LGBTQI plus communities. Firstly, it is important to recognize that access to prevention equipment is basic human right. Just as we prioritize access to health care services, medications and treatments, ensuring access to prevention equipment should be no exception. It is our duty to protect the health and well-being of all individuals, irrespective of their sexual orientation, gender, identity, or the diverse characteristics. 2 minutes. Okay, I'm gonna be short. Okay, let me just go.
Yeah, you wrote the whole speech, eh?
Yeah. Okay, collaboration and partnerships between different stakeholders are key to success. Governments, civil society forum, healthcare providers, and affected communities must work hand in hand. Only by doing so can we ensure that every individual, regardless of their background, is equipped with means to protect their health and safeguard their human rights. Amanda!
Awethu.
Amanda!
Awethu. Thank you, my sister. So now I will ask Comrade Monga Mutuku. I hope I pronounce it right, from Positive Women's Network.
Dumelang bagolo.
Dumela mama.
Le kae bagolo ba bana?
Re phetse le kae?
Teng. Bagolo. Wa itse ra bua ne. Ra lla thata. Ka jeko ko tswa yana. A keko. But ndinese di metso. Ke bua le the department. Dinese di metso. Gore ba re thusi le tshwantse le ba thusi. Batho ba berekang go tleliniking ba leka. Ba imetso. Ba bua ga ba utlweliwe. Rona ge re bereka le Ritshidze re berekela gore re thusana le batho ba department gore community ya rona e kere thuso e itlhokang. Ga re lwe se re slisang ko lona re leka fela gore le tlhaloganye gore batho ba ikutlwa yang. Re leka gore le tlhaloganye gore badiredi ba lona ba lebagane le eng letsatsi le leng le le leng. Rona re batla go thusana le lona gore re thuse setšhaba sa rona. The key pops go botlhoko ditori tsa bona ge re di bua go ntse yang ra tshega go monate mara go botlhoko. They go through the most. People living with HIV and AIDS. Go botlhoko rona o ka re yanong re matlhaodi mo gare batho ba botlhe. O ka re rona re tsamaya ka ka diboko la gopolane go te gona le ntata diboko o ka re ke rona re batho ba re tsamayng ka diboko ene ra tshwana ba botlhe ba ge madi a rona ba botlhe a red ba botlhe rona re le Ritshidze le di-organization tse di supportang re kopa le re bulele menyako ya rona ya lona gore rona re bereke le lona go thusa morafe o le tshwantseng le o thusa ga le batho ba sa siamang le siame le imetswe le lona re bulele menyako ya lona re le fetsebe le lona le re fetsebe. That's all we want from you. Ge le ka re utlwella ro berekisana bontle thata rona modimo o re tsere o re kgethile the way a re kgethileng ka teng gore re thuse batho re letleleng gore re thuse le lona gore le kgone go thusa batho for diphetogo di leng teng bagolo nna ka leboga ra di bona diphetogo go na le di-nurse batho ba berekang ko tleliniking the admin staff go na le batho ba e leng gore re ba phaphathela matsogo every day although ga re bue because re imetswe ke dio tse dintsi tse di negative tse di etsagalang re palelwa ke gore re akgole ba ba dirang ba ba lekang ba ba kgonang se segolo fela se ke se kopang ka jeko ka thusa ke ntse ya ka ya bofelo re bulele menyako ya lona re kgone go dirisana le lona fela ke a leboga bagolo
Ra leboga ngwaneso. We were supposed to have Rev Harane from Sanarela Plus. Unfortunately, he got a notification about the funeral this morning, so he had to go back home. And we were supposed to have a tech leader, Lebogang Musana. Unfortunately, due to unforeseen circumstances, she couldn't be here, but there's another leader here sitting next to me, the provincial chairperson of Northwest. I nearly gave you my position. I think I can give you just 2 minutes as a leader of TAC now.
No, thank you, Chairperson. Bagaetsho, ga ke tlo nna motelle ne. Ka la bona ke le motelle. I'm just going to speak to 3 issues. Load shedding that is affecting our facilities, and I do believe that most of facility managers are unable when challenges rise, more the issues in. So this note I will speak to district directors. I think some of facilities really we need to ensure we fix the challenges in some facilities of the generators sometimes due to a lack of diesel, nothing. And I will really highly request to say that district directors engage facility managers about the challenges because what we experience when we are monitoring is to say shortage of diesels is in 2 other ways. Either haya rikiwa or either staff harifik sinadi nalanyana. So you need to emphasize on that because it is really affecting the services sarona. That is why at the end of the day a problem ya gore patients ba tla retainiwa because some admins ba khona go etsa mmereko wa bona, then pharmacies ba khona go dispenser because of load shedding. So when coming to issues of key populations, this issue really it's a growing cancer, and we really at heart to find ways of mitigate more issues in the. And I will also say that as organizations and as Ritshidze, I will also request KPs to say now it's time to hit the ground. We need to start to make noise. There's a saying that goes, a chairperson, that says, if the mountain doesn't come to you, you must go to the mountain. So I think we have spoken enough and with not enough of advocacy. Now it's time to say that come and join PLHIV sector so that we can make our demands in the right. So, and one of the things that I encourage district directors to say there are meetings at district. And I think in other provinces, the district will call Ritshidze to come to say that maybe fortnightly let us meet. Our doors are open, Makaudi, to say that let us get the schedule of when are you meeting in the district so that we can come together to resolve things, they can be easily resolved in the facility. But because of the facility managers, Havana the efforts or Havana those authority, but it can be easier for Lona, how do we work together on that? And on that note, Sister Lindwa, Geratore for the facilities, yes, they are doing well. Rata hore wetsi re chapela matsogo. And we will always support and we will always show you the gaps tse di leng teng as re tlo bereka together. Unlike previously, Makaudi mo neng ke tena ra go tlhana ka ditlhogo. I thank you.
Raleboha leadership of people living with HIV. So without wasting any time, I think it will be good for me to call the provincial chairperson, civil society provincial chairperson, before I call the partners. Rep Nampimano, my leader.
Thank you very much, Mama Danki. Khotsomba gaetsho. I'm going to be very short because Nako, it is against us. But first and foremost, let me, because we are launching this report and it's a 3rd edition, I'm proposing adoption of this report. Thank you very much. It's seconded according to the process. Now, before Kia Khakala, let me start by saying, Madiba once said, health cannot be a question of income. It is a fundamental human right. So meaning, we need not be wishy-washy about issues of healthcare. Mare, I've got some few recommendations more. And I wanted to say something around issues of Hippocratic oath. Looking at issues about Florence Nightingale to say, perhaps we need to ask people, especially those who are doing wrong things, are you at the right profession in terms of doing service delivery? And I can tell you, part of the thing we need to do as Ritshidze is to check or anaba twabamo bana passion. Man, question how do you assess passion? It's a challenge because some of the people probably battle because on merego and therefore they are here, but the passion is somewhere else. Maybe some of them they qualify to be umakeneke, bomutakas, but because of unemployment, issues are critical. So, we are saying relay civil society. We are going to push for which is very critical. Governance structures, the clinic. Currently, in Northwest, there was a circular, they are on hold. So what we are proposing and what we are going to do as civil society, all across the province, we want to deploy members of civil society to sit in those clinic committees. And then what is going to happen moving forward? In our quarterly meetings, local, district, provincial, we want to know what is happening in terms of the governing structures, the civil society. And let me be clear, we are very intentional about that. So all the sectors, by law, once we participate through this, we will make sure in your 4th edition, we must get a proper report now that will be talking about governance, clinics, committees. And we want to see you guys participating there. But also, in conclusion, Chairperson, you see, one of the reasons the healthcare in South Africa is very poor is because, let me start by saying, during NHI roadshows, I stood up, asked even the parliamentary committee there to say, which medical aid are you using? And majority of them, they were saying this and that. None of them were using public health facilities, including some of the staff members, MECs and so forth. So it's very embarrassing. You giving us a service and yet you are not using it. Now our call as part of transformation agenda of civil society is that we need to look at the Sankara-East approach. Government officials, if you are a mistress, Kenyangwana Moskolo, public school, how health practitioner, Oskabafua medical aid,
And only if you can do that, I'm telling you, public services is going to improve. Do you agree? And I agree that Eludiki, you just said something very important now to say, load shedding is a crisis. And 8 and 9 June, Go America, there was what we called multi-stakeholder approach in terms of we were preparing for September, multi-sectoral meetings. And part of the thing we submitted was that Honale modelo bitong PPR, pandemic prevention and preparedness response. And we were saying, perhaps, most South Africa, we must agree that Motakas must be declared a pandemic. So that if electricity is declared pandemic, then there will be a proper mechanism in terms of disaster management. But until we do that, I forget. So lastly, in conclusion, we are saying, Relay Civil Society, in partnership, Kappa, to amplify the call, we still say, Mama, let TB be declared emergency. Thank you very much. Ke a leboga.
Thank you very much, my chairperson. Now I will start to call partners, and then unfortunately I will end with you, Department of Health. You'll be the last on my list. Hope you will you'll be patient with me. Today we are joined by Tebogo Dinka Dioka. Handwriting. Yeah, handwriting it's very wrong. I know there's business card here, so that I can pronounce the name. Yeah, Dioka. Tebogo Dioka is from the Office of the Health Compliance Standards with us, because Ritshidze started to have conversation with them to know, to tell them what is happening, and also they need to do their part as the entity that needs to look at that. So I'm going to call Tebogo Dioka just to give you give us your reflections of today's.
Okay. Ke a leboga chairperson, e re ke eme ka. Yeah, what a day. Yeah, is it afternoon already? Yeah, good afternoon, everyone. My name is Tebogo Dioka. I'm representing the Office of Health Standard Compliance, as well as the Office of the Health Ombud. You remember recently we just have a new ombud appointed after the departure, Yantate Malekapuru Makhoba, whom I worked with very closely, Life as Dimeli. The Life as Dimeli report that you see, I produced that Life as Dimeli report that is taking people to court. Some premiers, former premiers are losing their work, their employment. All I want to say is that the messages steadily today were somewhat disheartening and at the same time encouraging. And I like what Mme said, because that is true. Under this tent, but so South Africa from all angles. We put a question there one gore mara re lawyer ke mang. Mara re lawyer ke mang. A o Google, a o kry mo Google. Gore pila re lawyer ke mang. E ka right o ya pila. E ka re ka adopta attitude ya gore we all do the right thing at the right time, the right way. Each one of us. As into I hiretsweng ka tsela e right e leng expected. A re kope favor. Patients are not asking for favor. Here ya clinic, government ya clinic. E tloga ena le di patients. Manese asala di patients morago. Clinics belongs to patients. Sometimes we tend to forget. Because ke modiredi puso, I said ke tla go OHSC. OHSC is a government entity. Ka 2013, Minister of Health, the Parliament, they amended the National Health Act by creating Office of Health Standard Compliance. E re sebetsang ko yona re ba ba 4 ke na le ntate Medupi mola le ntate Advocate Mashao le ntate Madoba re tlhaga ko Office of Health Standard Compliance. So Parliament ke tlo ba short mme ke tlo share. Parliament he amenda National Health Act to create these two bodies, ya Ombudsman le ya Office of Health Standard Compliance, is because of the 6 ministerial priorities still di tsebang. Le boletse ka tsona, I'm not going to repeat them. Availability of medicine, cleanliness, patient safety and everything. Le taba ya gore we are preparing for the NHI. So go Office of Health Standard re-inspector the private and public hospitals. Ka o tshwana re na le dithulo tse re di berekisang, re na le di norms and standards that are regulated, ra ya mo ditleliniking tsa rena mo Northwest all over the country, and the inspector ka same standard and norm, because we prepare like NHI. Ka NHI you'll be going anywhere you want to go mo eleng gore the facility is accredited. So her facility ili non-compliant, re tseya action against the person in charge of the facility. Ba bangata ba tla o botsa, they have already received written love letters, you can call them. Yeah, but we call in the act is called written warning. Or RFA, somebody that is in charge of that facility, RFA reasons why they continuously fail to bring the clinic or the hospital to acceptable norms and level ya compliance, ya di health and norms and standards. So we are busy. Those that are compliant but receive a certificate that will allow them to participate in the NHI. No facility, no health establishment is going to participate in the NHI. Whether ke private, ke Netcare or Life Health Group or whatever, Mediclinic, or a clinic ya ko Montsane or ya ko Unit 9, ya public. No facility is going to participate in the NHI. Resa a certificate go officing. Now, what is encouraging is that all your findings, fortunately we had a chance to deliberate on a report last night. We had a 3-hour session unpack a report to Yalena. All your recommendations are in line with our findings as the OHSC. Ntato fetsa go bua just now ka governance, ka di clinic committees. We go throughout the country. The inspectors are 48 who are limited, and we must inspect 4,800 health establishments. Le di surgery tsa di doctor tse di leng mo di molong, le di ambulance wa check gore finally the requirements, the oxygen, whatever, to save lives. So we are still short-staffed, but we're hoping we'll get capacity. Heba rolla out NHI. Ha ke batla go ya lololo, ke batla fela gore mme o boletse ntwe engwe gore Ritshidze can only do this much. Each one of us in South Africa should be a health activist because of situation in the country. We cannot allow situation where we expect other people to correct the system for others. Ke thabetse mafoko a bolelwang ke bontate mola ba demanda the service. Kuri ntatolo wa ko Taung a demanda service a re military tools, because what's eba gore it's a promise e filwe ke constitution ya republic. It's not a favor. Ke constitution. To the Department of Health, we're working very closely. I just want to mention one thing. Our comparison, here we compare the provinces of South Africa. We find one province that is doing very well, KZN. And the reason is very simple. They're still maintaining that system where every clinic falls under a hospital. Pilong Hospital, and all the clinics in this area, whether they are 20 or 30, they fall under that hospital. That helps because there is no way the hospital will have a drug, but the clinic, they short the same drug, because it's the same person that is accountable. Good clinicking, it's the same pharmacist. What do you think? What do you think? those clinics, they get the drugs to tlamehileng ba di thola. So we found that system ya rena to be working. It used to be like that in the past in this province, but it has since changed, and it created a lot of red tapes. O thole le hore you sign documents, di saya districting, ke a leafing, ke a di tlohella mo tafoleng, and then ke tla di bona ha ke khutla o mongwe ha kgone di pusha and such things. Anyway, to all partners, Ritshidze, this is a struggle. It must continue. The Office of Health Standard Compliance and the Health Ombuds Office is there to support you. The two offices have a website which you can visit anytime. The Ombuds Office does receive complaints and assist members of the public. You have seen from our report here last year where we dealt with more than 20,000 complaints. But we know the complaints regime, how it works. You must start at the facility. Only when you don't get any joy at the facility level, you can escalate the matter to the Office of the Health Ombud. Thank you, and good luck. Modimo are bless.
Thank you very much, Ntate Tebogo. So without also wasting any time, I will not repeat anything what one once said, because I'll be taking so much time. I think all kaofela re na le ditsebe, ra utlwa. Ke tlo kopa somebody from Oram Institute. Thank you.
Thank you very much, Chairperson. Nakenna Glenn Mohapi from Oram Institute. Oramo, we are designated district support partner. Footprint ya rona e mo di districting tse tharo, ngaka Modiro Molema, Bojanala, gammogo le Dr. Kenneth Kaunda. We have noted the presentations and the report. Re itumeletse mo re boneng gona le improvement teng. We have also noted areas of concern, for example, staff attitude, gammogo le index testing e leng gore it is partner driven. Re bereka alongside the Department of Health, and in most instances, ke rona ko Oramo re dirang index testing. We acknowledge mo go nang le di challenge teng gore we going to sit and make the corrective actions alongside with the recommendations that have been listed. So ka go rialo ntle le go senya sebaka re acknowledge a report, re dumela gore re a go improve. Ga re compare ngwaga e report e le the previous one, re bona gona le a marked improvement, me re a go dira botoka thata go feta fa. Ke a leboga.
Ra leboga ntate. And then we will ask somebody from TB HIV care. I think they are working mostly with key populations.
Dumelang colleagues, Khalalelo Letseka, social worker from TB HIV care, sex work program. Chairman Rudrile, was outlang agiti matata etlebele ne, Rudrile, and then truly it's disheartening, especially coming from the key population sector. It's disheartening. We know these challenges. We dealt with them. And then the sad part, and equally disappointing part, is that TB/HIV care, we do provide sensitization training to DOH, especially in the DKK area. So I'm disappointed personally because I'm the one who conducts those trainings. So I'm personally disappointed to hear that we still have these challenges after about 3 years of continuous sensitization to DOH staff. Admittedly, it's not all staff. We depend on the ops managers to let us know who's available and whatnot. So to be fair, yeah, it's not everyone, but I believe that when we provide sensitization training, those who are trained, they must go back to the facilities and share the knowledge with others. But really, where we have failed, we will improve. I'm saying we because everyone, we each have a role to play. And hopefully next year when we come back, you'll be having a huge smile on your face, Chairman. Ne? So thank you so much.
Thank you very much, May. Now I will call for a person from the District Department of Health. If there's one. You've been looking at me like, when are you calling me?
Thank you, Chair, and good afternoon, Ritshidze, the partners, our clients, the KPs, the officials from the Department of Health, and everybody who's here and have contributed to this report. Good afternoon.
Good afternoon, ma'am.
Chair, today, because I see myself as the furniture of the feedback from Ritshidze, today I don't have words. The only thing that I can say is that, Chair, we acknowledge the report as the Department of Health and the contents thereof. And because I was here when you did the second one, and I was sitting there looking forward to see what I saw the last time. But with a surprise, I see that the commitment that the department have made to say they will try and implement the recommendations from Ritshidze. It looks like step by step we are getting there. And we won't lose hope. We will continue to try and provide our community with the quality of service. And I must acknowledge the issue that there is a lot for our staff. And we see currently it's getting worse. But as the department, we are not sitting and looking at this situation and not doing anything. We've got proof that we have started to implement something to support our personnel so that they can be able to continue to serve our community. We will definitely take these recommendations and go back to a drawing board and see how far we have gone and how far can we still go. And it's true that we've got shortage of staff, and the department is trying and doing something about that. And I'm sure you have been seeing the adverts in regard to posts and also especially the critical ones. And I'm sure next week again we'll see some adverts. Even if there are financial constraints, the department is trying its best to fill these critical posts so that we can be able to meet the needs of the community. And we are not only looking at the health professionals, even those that are non-clinical, the department is also giving attention to. At the end, I would like to thank you for the work that you are doing, because sometimes when you are in that office, you won't be knowing some of the problems. But when you go to facilities, sometimes what I see, it won't be the same as what you'll see when you go to the facility. And as management, we are not only sitting in the office. We go to the staff, we go to facilities to meet them and show them that we are with you so that they can have strength and they can be motivated and continue to serve our people. I've noted the critical issues from the recordings. I will contact the relevant districts. I'm from Ngakamudiri Mulema. I forgot to introduce myself. I'm Mosela Mukutswane Kaudi, the Chief Director of Ngakamudiri Mulema. So I will take the issues to the relevant, I was noting, to the relevant district managers. After this, if the others I did not see them, if they can come, and then I'll take the contact so that when I talk to the districts, I'll be able to say, here is the name and here is the cell number. And I will be their advocate. Thank you very much, and God bless you.
Thank you, Mama. I think in terms of the contacts and the cell phones, Mary and Ludik and Londi are the best person to assist you with and connect you with the patients who still need assistance, because we don't want just to sit here and talk and live as if we were just doing one of the talk shows. It's not a talk show, but it's for us to fix where there are problems. So now I will call somebody from the Provincial Department of Health, if there is any. I'm not sure whether we have. You were representing both. Okay, it's okay. I'm just told that we have someone from the Premier's office, and it will be wrong for me not to give Ms. Noe Mulamu a moment to say something, since she's here from the Premier's office. I feel like we are honored, we are respected, and we really appreciate a person from the Premier's office. We don't often get people from Premier's office attending our community accountability meetings. So I would like us to welcome her by clapping hands for her and welcoming her.
Dumelang bagaetsho.
Dumela mama.
I'm from the Provincial Council on AIDS. I thought for my chairperson, Ntate Pinampi, has covered us, but Raleboha. I want to thank Ritshidze for this platform, because indeed we can see that there are improvements since the first report. And there are human errors, of course, but once the platform has been created, that is where we can iron out issues and pick up those that we have to run with. And we can only thank God for that. And as we move forward, also, revisit your database to check the clinic committees in this meeting. And if those members by the clinic committee they will be in a better position to give support to the clinic managers and the staff. Thank you very much.
Thank you, Mama. Thank you very much. Thank you very much to everyone who is part of this meeting, and I'm so glad that we started the meeting with the tent so full, and still people are still here. In most cases, by the time we end the program, the room is half, or it's half full. So yeah, we are really happy. And on the issue of clinic committees, I think we are working towards that, Mama, to also monitor to say which facilities do have clinic committees, because that is very critical in the work that we are all doing on the ground. So, colleagues, I think we've taken a lot of your time, and Ogashabala Lumtuana Ritshidze team, City Asbonge ngumzulu ke mina ngumswati. Sengibuyela kwela kithi ke manje yakhuluma. Ngikhathethe ukubua. But luckily I'm from Gauteng, so I can utilize. Yeah, relebogile. But ke mogana gane. Khona lokho. Yeah. Yes, Khumnagan. Hoba teng hwa lona, and hoba available. The patients, thank you very much for your braveness to come and speak about your stories, and the patients who acknowledge what good is happening in facilities. Thank you very much for being honest, because in most cases, one potato, but it rottens the whole bag. And we are unable to pick those ones that are still not spoiled, and we want them, all of them, to be spoiled. So we can't throw the whole bag of potatoes because of one spoiled a potato. So thank you very much. And again, Northwest Department of Health, Provincial AIDS Council, and everyone, the improvement. You know, as much as it comes slowly, but we really appreciate it and we acknowledge it. And we are hoping that, yes, the 4th edition will be smiling more than what we are doing now. Thank you very much, and colleagues, thank you, my comrades. And I think there is something to eat. For those who are here, there are refreshments. And for those who have joined online, thank you for being with us for, I don't know how many hours, but yeah, you've been here with us patiently listening to the stories. Thank you. Continue to follow us at our website, ritshidze.org.za, and at our yeah, handles zonke lezo zinto. Tina, we were born before technology. Yeah, so we know now they have TikToks, they have all those things. Tina, we were born sisabhali letter. You know, at school we were taught how to write a letter to a friend, not how to WhatsApp. So those things into zamanje, but follow us on those things zamanje with social media. Thank you very much, colleagues. And there are refreshments on the back. Thank you. Have a nice day.